relation, the lesion is afflicted. So mostly this is a case of most likely it is a malignant lesion of the CFS included the nuclear complex. Because there is a nuclear complex almost distorted. Sir?
Why?
Sir, the melanoma also, sir, the character of the melanoma is the malignant is around the ABC. Around this it is a large asymmetric lesion, sir. This is a irregular border, and there is a color variation of there is also there is no alteration. It is a quite subtle melanoma.
But the location is not. It is not the common location for melanoma to happen. Second thing is, when you are raising the hand, it is going up also. So does melanoma will do that? Melanoma to become so much invasive, going to the deeper structures. So how will you say what findings or you will elicit in the patient in history and examination to rule out melanoma?
Sir?
In clinical examination, how will you rule out whether it is a melanoma or a breast lesion coming to the skin?
Sir, I do the patient, sir. In the sitting positions or bending forward position and by the technical and by the patient and also the line of position. In a daily position, having so much of this population, the patient will be not mobile. Measure will be not mobile, but in case of melanoma, sir, if it is not good, it can be
One more point in history also you can ask something that was. Would you like to ask something to rule out the melanoma or in history to the patient? Straightforward, this melanoma can't. There can be a mole. You can ask the patient to be, was there a mole that has increased in sudden in size, a sudden increase in size. Ulcer, sudden increased.
So what are the five signs of conversion of nevi to melanoma that you want to see in the patient to confirm it is melanomatous conversion?
Yes.
Sir, there is a acicular border, there is a color variation, there is an ulceration,
Size sudden increase in size. What else?
Bleeding.
Border.
Bleeding is there. Satellite nodules around it. So regional lymphadenopathy. So these 5-6 things are there, then you may suspect that there is a conversion of it. So your first differential is melanoma in this case, or CFS?
No, sir, my father is CFS.
How will you proceed?
There is no visible fullness there.
Yes.
Or it is either it is totally also proliferating which has just.
Right, exactly. It becomes difficult to identify on a picture. I can see that also. Yes. This can be a
post chemotherapy setting.
Right.
Maybe post chemotherapy setting where everything has gone so shit because of neoadjuvant protocol. And now you can see there is a healing, the skin has come over the ulcer and everything, he has responded quite well. It may be that situation.
So Minal, the patient comes to you, it's a post-chemotherapeutic, suppose NSET has been given, and now how would you proceed to this patient?
So post-chemotherapy.
It was ER/PR negative, HER2 positive, LABC.
Sir, we should like to, sir, again, sir, see the response of the therapy, sir. Whether it is increase or it is stable disease or it is progressive, sir. If it is, sir, response is there, sir, and on clinical basis, sir, again, sir, then we will like to, sir, go for this.
How will you evaluate the response? Clinical, radiological, how will you evaluate?
Clearly, sir, the measuring the site on the previous mentioned and this experience, and sir, if there is any previous finding of infertility, we can also assess this, and we can assess that clinically, or if there is doubt, we can also use the same indication we have done previously. If we have done the test scan, we can also do the test scan. We'll say indication is better. Or
General question: PET scan whole body versus whole body MRI, which is better?
sir, test scan whole body is sir better because it's a single indication. We see the test looking at the recent metastasis. We see the
DWIG MRI is sensitivity more in comparison to PET scan. Whole body MRI, DWIG scan has more sensitivity in comparison to PET CT scan.
whole body MRI.
40 minutes, 45 minutes. आउट ऑफ है ना, तो मतलब कैलकुलेट करोगे ना लास्ट में इसलिए. हाँ जी, इंट्रोड्यूस योर सेल्फ.
Good morning, myself, Dr. Klaus from Ocrober Interstate. Dr. Samadhi from Marwan Interstate.
Third year resident.
Yes. Good morning from Marwan Interstate.
So, as per sequence, you have to first.
All are third year. Here, for the
Spot diagnosis.
Third reason was the because to the area of light.
Pradeep, listen to the question, right? Don't be anxious and fast. Spotter diagnosis.
So, first you have to characterize your findings, then according to that you give. उसको describe कर दो पहले.
ठीक है.
Describe करो.
Some origin from some third reason. Elevated margins, slight slump on the base.
Why it is not aphthous ulcer?
Yes.
After this, we will be flat.
What else? What else? Aphthous never has punched out appearances. Punched out के दो differential होते हैं, या तो punched out regions के दो differential होते हैं, क्या क्या? 1 and 2. Tubercular never has a punched out. वो tubercular के होते हैं. Syphilitic ulcers are punched out ulcers, and second is malignant, rarely to see. What you said is a tubercular ulcer is undermined and a bluish edge all around. Goes more in favor of tubercular ulcer. So what else? And the aphthous ulcer will have surface sloughed out mucosa also. Generally you will see on that. in those cases of this ulcer. ठीक है? Undermined edges, there will be a bluish ring around the ulcer edge. Diagnostic of tubercle. What else? How will you proceed?
I will take a punch bags from the margin.
No clinical exam, oral cavity examination.
Full oral cavity examinations. Clean the oral cavity in hand, and then proceed the punch bags.
So you should say and take a complete history, examine loco-regionally as well as systemically, and then evaluate the case. How will you investigate?
On punch bags, it is marinate, and on clinically, it's oral cavity is less or normal.
You take punch biopsy from this lesion. This lesion, you take punch biopsy from the lesion. What sort of biopsy will take?
Margins.
How will you take?
After proper consent and after the infiltration of the lignocaine.
Which lignocaine?
Lignocaine.
With or without?
If patient does not have a cardiac state, we can use the adrenaline, a contraindication for adrenaline cardiac patient, then only.
Okay, then.
When you take incisional biopsy, when you take punch biopsy,
if the lesion is very small, less than 1 centimeter, then we can excise margins.
Question is when it is
Incisional
indications of incisional, indication of punch biopsy.
Not excisional biopsy.
What are the indications?
If on examination it seems having invasive disease,
in cases of proliferative lesion, what kind of biopsy?
you can proliferative lesion we do the invasive incision biopsy to the margin area to do the transition zone to the.
In cases of ulcerative lesion, what biopsy you will take? In cases of proliferative lesion, what kind of biopsy? Indurated ulcerative lesion, no proliferative.
This is ulcerative or proliferative?
Ulcerative.
Ulcerative. Now tell what would you like?
In this case, we would like to do a wedge biopsy from the edge of the ulcer and closing that effect with a vacuum. Because punch biopsy will not be possible.
Suppose you have taken punch biopsy, it has come to be a malignant lesion. Oral cavity is seems nothing in oral cavity. Neck seems to be clinically N0. Now, how would you like to proceed in this patient?
Because it's a T1 lesion, so we can counter patient about give the option of about wide local excision only or wide local excision.
Whether would you like to go for any imaging in this patient, or you would directly like to go for surgery in this patient? I want to ask that. जो है बोलो उसमें सोचना क्या है?
Sir, as such a clinical,
बोलो उसमें why you इतना हाँ बोलो क्योंकि मैंने बता दिया ओरल कैविटी में कुछ भी नहीं है, नेक क्लिनिकली कुछ नहीं है, छोटा सा लीजन है T1 What will you do in this case?
you can do both option wide local excision and observation of the neck or wide local excision with selecting neck dissection.
Any other options you have? N0 neck with T1 lesion of 5 millimeters.
Or
6 millimeters.
different radiation helps.
So start like this, that we'll discuss the case in MDT and tell the options of radiation and surgery, and then this will proceed. You should always discuss in MDT whatever you, whenever in the exam, you speak now, we should every case discuss in MDT and then proceed. That way you should. How will you do Videxin and what reconstruction? What are the options of reconstruction in lip lesions?
Lip lesions.
So, if it's involved, it's near midline and it's if defect is less than 1/3, then we can close primarily. If it's more than 1/3, then we can do rotation flap, ascending flap.
What is abyss and what is ascending?
Ascending flap on the when we do the superior inferior labiated based tissue rotation from the upper to the lower or lower to upper. In this ascending flap, the angle of mouth is intact. But with the ascending, we use the angle of mouth and then new angle of mouth to the ascending flap.
So your answer should be if it's only mucosal lesion, dysplasia, or we can do mucosal advancement, local reconstruction. The depth is involved, then we can, as you said, the rest of the answer continues.
Sir, there is a lump in the submandibular region or
It is
What are the
below
boundaries,
ear.
what
It
are the
is-
boundaries of submandibular lesion?
sir, submandibular triangle.
Ah.
Submandibular triangle, superiorly it is bounded by the lower border of mandible, interiorly by the anterior area of digestive, and posteriorly it is posteriorly.
So what is this lesion situated in the submandibular triangle?
It is overlying submandibular region and carotid region.
No, tell it. It is a parotid.
It's
Why you
more of
confused?
parotid
Ah.
in level 2 area rather than submandibular. Though you don't have a full picture, but what appears to be like that. Okay, continue.
Sir, there is obliteration of lobule of ear.
So if you are saying operation lobule of the ear, does the submandibular swellings go
No,
into
sir.
that level?
No, sir. This is the carotid region extending.
Say like this. You
Yes, continue.
It is likely to be, sir, carotid region.
Describe to us the lesion.
It is a well-defined.
So whenever you describe, now if I have closed my eyes, I should be able to make the picture what you are saying.
size.
That's the way you should
Same.
say. Right side of the face, below the ear lobule, I can see a globular swelling with smooth surface.
Approximately
Skin is
size.
this, size is this, location is this. You should be able to make out the picture what you are saying.
Sir, around 6 by 5 centimeter size, well-defined globular swelling over the parotid region with smooth overlying surface, and overlying skin is the stretch, and
What is the parotid region? What is the surgical anatomy of applied anatomy of a parotid region?
sir, parotid gland is boundaries of parotid gland posteriorly is related to the external auditory meatus.
Canal.
Superiorly it is bounded by the zygomatic process. Anteriorly it is
Zygomatic arch.
zygomatic arch. Anteriorly it is bounded by the masseter, posterior masseter muscle, and inferiorly it is bounded by the anal.
So do you think this swelling is in the exactly parotid region?
Parotid lobe enlargement.
Apex. Should say parotid tail or parotid apex swelling. That will be better situation. No? If you say parotid swelling, I think it is here. If you say parotid tail, I think it is here. So your description should be like that. How will you manage?
Sir, first of all, I would like to
अरे बेटा
ऐसा क्या करता है, ऐसा क्या करता है? सरकारी आदमी साइड में रहता है.
First, I would like to go with the history and physical examination, origin, duration, and progression of the swelling, and then I would like to go with it is likely to be parotid slightly gland swelling. Then I would like to go with MRI.
What in history more would you like to ask to the patient?
Sir, onset associated with pain or not,
What more?
or history of fever.
More.
So, what is the first reason? You were bang on parotid always. Why did not you discuss about lymph nodes in your description here? It can be a lymph node also. Can be a lymph node involved in lymphoma also. What is that? Can be there. What else? Can it be a ranula?
Next, it is not location.
Location.
Any relation to meals?
So you should classify your answer like that. That if it is only confined this area, it may be first differential lymph node and second is carotid. If there are multiple chain of lymph nodes all over the body in examination, I'll think more of lymph node. Classify your answer. Then come to one point. I said it's carotid, for example. You said there's nothing lymphadenopathy, clinically soft, tongue, hard, whatever you said. Intraorally you will examine. Then it is what finding you will find in deep parotid tumors.
Maybe there's some stone in the parotid gland there. May also.
Bilateral examination.
Yes.
Relation, pain relation to the meals.
So it's a soft swelling on palpation, fluctuation present. What you will do?
Sir, I would like to go with MRI also. After the clinical examination.
What in MRI? What would you like to see?
Sir, most of parotid lesions are cystic in nature because of MGUMST. If there is any solid component or heterogeneous.
A single question. Why not sono first? Sono, USG. Why? You say after clinical I straightforward for MRI. Why not sono? You can achieve something with sono or not?
That's a big thing.
So there are things, practical things are there. You have to address the things accordingly. Because it is fast. You just send the patient and within half an hour the report with you. This is this and this. Even they tell you about the origin. Something from here or something is a good. If sonologist is a good one, he can tell you. Then you can go for MR as well. Right?
So we had gone with this imaging. Now your time.
Sir, it is a homogeneously very fine lesion over the parotid lesion.
No. Don't say that. Say first what section it is, what location section it is, and then describe the pathology and normalcy.
It is a picture of it's a section of CT scan.
Why it is not MRI scan?
Sir, bone is up here.
Bone is white. What does whiteness mean in bone in CT?
It is a radio.
To say that word has to be used. It is not intense. Intensity is used in MRI scan, right? Okay, then continue.
There is a homogeneously enhancing lesion, well defined, sir, in the parotid region.
Right or left?
It is right.
Yes. Why not left?
Ever see the film?
Yes, sir.
From where to where the cut sections goes on?
Sir, so, in the CT scan, we scan.
It is axial, na?
Yes, sir. Yes.
So how it is proceed?
So you are standing on the foot end of the
Yes,
patient.
foot
That's
end.
how you see the CT films are taken. You speak that thing. हमारा पूछने का तात्पर्य है कि आपको बेसिक मालूम है कि नहीं. So you should speak.
Yes, sir.
बोलते जाओ. बोलो.
Sir, periodic lesion swelling, homogeneous lesion.
No, no, you did not speak. It is contrast enhanced or non-contrast enhanced. You said it is homogeneous. I mean, what did you say? Enhancing lesion. But where is the contrast here? It is a non-contrast film. There is no contrast in this. And it is which window?
It is a soft tissue.
What is that? हटाएंगे क्या फोटो पे?
Soft tissue.
वैसा. ठीक. Next.
This photograph is of foot in which you can see small black lesions.
Which aspect of the foot?
Around the lateral aspect.
You say that, na?
Make it a habit. Whatever it is, in a
sequencing
single
is
line.
a-
In a single line. This is the foot on the side is this and this and that. That's it. है ना? So why we have to ask this thing?
If we ask these questions, it means तुम्हारे 5 नंबर तो वैसे ही कट गए. बेसिक में अटकोगे तो मार्क्स नहीं मिलेंगे. बेसिक में तो फ्लो जाना है एकदम. Showing the foot, showing the lower part of the leg, the ankle joint and the distal proximal part or whatever it is seen, lateral aspect. Now you start.
This is a small black lesion involving lateral aspect of foot of left leg. These are small ulcer at present at the edge of the discolored region.
Anterior edge, anterosuperior.
This is the edge of the discolored region.
क्या है? What?
This could be melanoma.
Features of melanoma in this case.
Features of melanoma usually it is described by ABCDE. A is asymmetrical enlargement of the lesion, then irregular borders, then change in the based on history we can ask the patient whether there is recent change in the size of the lesion or not. Then any discoloration, change in the discoloration in the lesion or not. We will look in the history last book.
So, how will you proceed?
First we have to take history of the
What is amelanotic melanoma? Types of melanoma. Classify.
melanoma ulcer
बोलो.
lentiginous
Acral lentiginous melanoma, superficial spreading melanoma, nodular and amelanotic melanoma. Which is most aggressive? Amelanotic melanoma. ये कैसा है? Normal melanoma.
superficial spreading.
How will you proceed?
After taking history, we have to do examination of the patient, whether there are any palpable lymph node on the lateral completed fossa or inguinal region. After careful physical examination, we'll
You should say पहले any satellite nodules or
in transit nodules.
what is the difference in the two?
In transit nodules, there are less than 2 centimeters.
2 to 5 centimeters is satellite and more than 5.
Distance from
Is in transit more than
Next
5
satellite is near.
so that you have to see the both nodules. You have to. Does it make a difference in your treatment plan? Does it make a difference if the satellite nodules are there or in transits are there? How?
Whether you remove them separately or you remove a hand block. Understand the point? So how will you?
If they are satellite nodules and within the vicinity of the primary lesion, we can remove the hand block. But if they are implanted nodules, then we cannot remove in the same excision area.
What is oblong resection?
Oblong resection is the type of lesion which we remove this satellite lesions.
What is the definition of oblong resection?
Hand block resection. Hand block resection is the removal of all visible lesion in total. In the same excision area.
With a good margin all around, 3-dimensional. How will you manage? Investigate?
After the district legal examination, we have to take tissue diagnosis from the lesion.
How will you take tissue diagnosis from this lesion?
We take biopsy, wedge biopsy from the edge of the ulcer, edge of the region, edge biopsy. And
Which area in this ulcer you will take, this lesion you will take biopsy?
so the area which is ulcerated anterior superior will remove that area with edge, triangular wedge. We take wedge biopsy and then close.
What is important in taking that biopsy?
So wedge biopsy is important because we have to take
What is most important thing you have in wedge biopsy? What is most important?
so the depth of the biopsy specimen.
Else?
Because
Or?
What else?
What else? Any wedge biopsy, what is most important thing?
So wedge biopsy should be involving two things. So it should be including normal tissue.
That is most important.
Normal surrounding tissue also.
As well as the depth is
As
there.
well as certain melanoma case depth.
Why normal?
So normal tissue because the maximum tumor activity and differentiation is present on the edge of the ulcer, and we can compare the region.
That is a comparison.
Surrounding tissue indication can be seen better.
Why not punch biopsy?
There is no significant proliferatory component, so that
Plus, in melanoma, depth is more important. Right. What else?
Sir, we can also go with excisional biopsy because reason is
It's a small
very
lesion.
and we have to take
So if you
one
think
side.
you can primary close it, you can go straight forward also. That it doesn't matter.
Excision biopsy. Good. Cheer कर दिया करो भाई सब लोग।
आप लोगों को अगर केस 11:15 पर है तो बैठ सकते हो। आप ग्रुप पे इनका केस
सर क्लिक करो।
आपका हिस्ट्री
बताओ, हिस्ट्री चालू करो। ये है बच्चे, अपने को इंट्रोड्यूस करो पहले तो, एंड देन स्टार्ट इंट्रोड्यूस योरसेल्फ।
Good morning, sir. My name is Dr. Kumar Agarwal, and I am a third year resident at Medical College.
Good morning, sir. Myself, Dr. Bhupendra Singh Bara from SMS Medical College.
Good morning, my name is Dr. Russell. I am a final year resident from Bhavan Marketing as well.
Good morning, sir. I'm Rajesh Krishna, a final year resident from Ocrober.
7 months back, which presented with distension of the abdomen, which is present for around 2 months duration. It was associated with breathlessness on exertion, but she was comfortable while lying down or while resting. There was no association of pain, no history of nausea, vomiting, No history of bleeding per rectum, altered bowel habits, or bleeding from the vagina. There is no, it was associated with loss of weight around 4 to 5 kgs in 2 months, and it was associated with loss of appetite. Earlier she used to have around 5 to 6 chapatis per day.
No, you should have spoken positive history first and then negative. You mixed the two.
So completed the positive. There was only one complaint.
But you said then associated with these 3 or symptoms you said.
Weight loss, decreased appetite, they are positive part.
So you should speak along with the positive history and then negative history. Continue.
There was loss of appetite. Earlier she was having around 6 chapatis. It came down to 3 to 4 chapatis per day. And there was no history of cough or blood in the sputum, low backache or jaundice. That completes my history of presenting illness. Coming to the past history, there is no history of tuberculosis, diabetes mellitus. The patient is hypothyroid. She takes 150 microgram tablet per day in the morning. She is also hypertensive. She takes 1 tablet in the morning every day. The details of which she could not elicit.
Duration?
20 years. There is the patient, the treatment history I elicit afterwards. Apart from this, there is no
Past history you should have said hypothyroid, hypertensive, whatever, and then no similar symptomatology or treatment taken for similar symptoms in the past.
Before this treatment, yes, there is no similar complaints in the past. Coming to the personal history, she has normal bladder bowel habits. She denies any alcohol or smoking habits. She is a vegetarian by diet. She sleeps normally. She attained menarche at around 13 to 14 years of age, and she attained menopause at 58 years. She is E5L3. She has first childhood at the age of around 24 years, then 26 and 28 years, and each of them was breastfed for a week.
What was the delivery? You did not tell them.
No.
Normal delivery. Normal.
And she had a tubal ligation 2 months after the third.
Breastfeeding duration?
Breastfeeding 1 year.
Each 1 year. More than that. Okay. Good. What else?
Family history is not significant. She does not give any history of breast, ovarian or prostate related carcinomas in the family, the first or second degree relatives. Treatment history, she had a staging laparoscopy around 5 months back, and there was a sample taken, after which she underwent 6 cycles of chemotherapy, and the last cycle of chemotherapy.
Straightforward staging kari. Is it?
They did a staging laparoscopy.
Straight.
Yes. She was taken up for surgery, and staging laparoscopy was done.
In abdominal distension patient.
Yes.
Straight ले लिया. Side एक टैप वगैरह कुछ नहीं किया था.
So what was done?
According to the patient, the sample was taken, and then she underwent 6 cycles of chemotherapy at an interval of 21 days each. And the last cycle was given on 15 September 2020.
So you saw the papers of this patient? No. So diagnosed as C ovary. No, I'm asking.
So we not seen the reports.
Oh, you have not seen the reports. Okay. Did not tell about the any history of drug allergy?
Yes, actually, yes, it is.
That is a must to do.
Yes, it is important if you are starting with chemotherapy. There was no allergy history.
What is a familial disease and what is a hereditary cancer and a familial cancer differences?
So in a hereditary disease, we know that a known cancer mutation is causing, and in a familial disease, there is an unnatural cluster of diseases in which the gene cannot be identified, but there is a history of familial cancer.
Cannot be
The
identified?
gene cannot be identified.
Has not be identified, but can be identified.
Yes.
So how will you identify in both, whether it's hereditary or familial?
So in hereditary, we go for we can go for the testing first. We can go for as an ovarian cancer, but first testing I go for is a BRCA testing, BRCA1 and 2.
Where from the tissue you will take?
Sample cancer.
Sample cancer loge in familial as well as in hereditary.
So where I can go for the when I'm going for staging, I can take the tissue as well as I can go for the serum sample as well.
For familial or hereditary?
For hereditary, it will be in ovarian. For familial, no, sorry.
For the germline testing, we should take from the blood, or for familial, we should from the tissue.
Why so?
So it can be a new mutation as well. It may not be hereditary.
That's what.
Then I would like to summarize my history. 58-year lady presented with abdominal distension for 2 months with loss of weight, significant loss of weight and loss of appetite, and also associated with pain. And underwent a staging laparoscopy, underwent 6 cycles of chemotherapy. No significant findings.
So what you will think? Which disease you will think you will shift to chemotherapy?
So,
One sir tell already. CEO. Else.
So there's abdominal distension, so it has to be in, it is a malignancy, abdominal malignancy.
Kya? What will you
Can
think?
be of gastrointestinal system also.
What? What is your differential now? You know everything, you've taken history, examination, 6 chemotherapy shit. What differentials you will put in?
So I put first diagnosis will be a gynecological malignancy, second will be a gastrointestinal malignancy.
What are the gynecological malignancies and what are the gastrointestinal malignancies?
The gynecological malignancies I would like to keep ovarian malignancy as my first diagnosis.
Why ovarian?
So because ovarian malignancy amongst all the gynecological cancers, ovarian is associated with commonly associated with ascites.
Ovarian is the commonest.
It is associated with
No, you can say ovarian is the commonest. Morning, sir. So first is ovarian is the commonest, and second what you said. Isn't it the commonest malignancy with ascites? If you talk of malignancy,
yes.
non-malignant ascites commonest cause.
Non-malignant ascites.
Commonest.
Most common.
In India. Second, cirrhotic liver portal ablation. So, what else? Next.
And amongst GI malignancies, I would think about can be a carcinoma stomach.
Commonest. Start with commonest. Is stomach cancer common in our part of the world?
No, sir.
Then, which cancer will have GI malignancy, as you said, will come with the commonest, will come with ascites? Or distension of the abdomen? Colorectal you will speak first. Right? Colorectal?
Colorectal.
On the local examination,
Alopecia. What do you know about alopecia?
loss of hair, sir.
So in this patient, why is there alopecia?
Patient receives the chemotherapy mostly, that is the reason for this.
So you can mention after some drug, or if you don't want to say actually, but if the patient is saying that she has not chemotherapy, then you can say immediately after chemotherapy, she had alopecia.
Patient told that she received 6 cycles of chemotherapy.
So there is no harm in saying that she developed alopecia after.
So which drug causes alopecia?
Sir, microtubule stabilizers, and platinum agents, alkylating agents.
So here, which drug might have caused alopecia? She is diagnosed as C ovary, as you said.
Mostly with the platinum agents, carboplatin.
Correct. Continue.
On local examination or abdominal examination, on inspection, the abdomen is normal with the umbilicus is centrally placed with inverted, and there is three scar marks are present, one in the supraumbilical region, one in the right hypochondrial region, and one in the right iliac region of approximately 1 into 1 centimeter. And there is no other dilated veins, no scars, no sinuses, and all upper quadrants are moved equally with the respiration, and hernial alopecia appears to be normal. On no cup impulse is seen on inspection. On palpation, on inspected findings are confirmed on the palpation. No localized temperature, raised temperature, and no tenderness are present. And
before this, in the past history, did you mention about cholecystectomy, appendicectomy?
no, sir. She underwent the staging laparoscopy, diagnostic laparoscopy procedure, and tubal ligation.
But right hypochondria?
Those scars are only because of the surgery.
So you should describe, because the moment you say this, I come new. I will understand that she has a right hypochondrial scar and a right iliac scar. So that is cholecystectomy, appendicectomy, that is that. So mention this big scar. Otherwise, if it is a big scar, you will say she attributes this to cholecystectomy, which is already had, and that scar.
She underwent a diagnostic laparoscopy and staging laparoscopy and also got tubal ligation. Most probably.
Diagnosis in this case, patient already has staging laparotomy and chemotherapy taken, so your only diagnosis is there. Only diagnosis is there. You already taken, so what will you think the other diagnosis you will make after? Understand the point? It is a clear-cut case, straightforward case. So there is nothing like the second option is used. You already treat the patient,
Post chemotherapy.
So you treat, the treatment is already started with the patient. So there is no other diagnosis will be there, So it is a single diagnosis, it's clear-cut diagnosis is there.
Carcinoma ovary, post chemotherapy.
That is whatever. That is straightforward because they already taken. You started the treatment of the patient. So no, there is no provision. Nothing is there.
Debate.
The patient would have received neoadjuvant therapy for any other finding as well, sir. I have not checked the reports of the patient as well. I don't know whether it's carcinoma ovary, could be carcinoma stomach.
So what other things can be there?
She does not give history of radiation, sir. Okay. She only gives history of neoadjuvant therapy. So most likely.
In which cases you will give neoadjuvant therapy in abdominal distension patients after a biopsy.
She probably borderline resectable or unresectable carcinoma pancreas could be DRTC. Maybe she was only receiving chemotherapy for it.
One single thing.
How do you know it is neoadjuvant?
So she said she's been planned for surgery. She's been admitted for the sake of surgery.
Second
she received
thing.
the last cycle of chemotherapy before 1 month and 5 days.
Okay, you say borderline carcinoma, pancreas.
Yes, sir.
In how many cases staging laparotomy done in ascitic patient in pancreas? Is it borderline then?
No, sir, it won't be borderline.
Does the borderline has ascites so much as you said?
No, sir.
Never. It is a clinical.
नियोजन प्रोटोकॉल
So the colon we don't usually unless it's
Pseudomyxoma peritoni क्यों नहीं बोल सकते? Appendiceal carcinoma.
Monish, तुम बताओ.
No.
Anything else?
The patient might have been just consoled कि तुम केवल दे रहे हैं बाद में ऑपरेशन करेंगे. You don't know it is true. So it might be advanced disease of anything, and patient is being given chemotherapy, not exactly neoadjuvant, but she must have been told कि ठीक है तुम्हारी दवाई देंगे फिर ऑपरेशन करेंगे. So keep that in mind also. Don't have fixed.
This is very important. Plus,
ulcer, non-healing ulcer over the right buccal mucosa since 6 years. And patient also complains of pain over the ulcer since last 2 years. As my patient is a diagnosed case of carcinoma right buccal mucosa, and he underwent some form of treatment at our hospital. And last treatment was done on 19th of October, 19th of September.
And like beginning, how long duration you were saying? Some last
6 years.
He had treatment. He's been having treatment for the last 6 years.
No, sir. He is receiving treatment, some form of treatment for the last 2 to 3 months.
2 to 3 months.
Yes, sir. And last treatment is form of IV, some drugs given on the 19th of September.
Confusing. 6 years की history पूरी बताओ.
Yes, sir. According to the patient, patient was already 6 years back when he noticed a small ulcer over the right buccal mucosa, which was initially around 1 by 1 centimeter and gradually progressed to the current size of around 4 by 5 centimeter, 4 by 4 centimeter.
In 6 years.
Yes, sir. Patient also gives history of the lesion was insidious in onset, gradually progress to the size of around 4 by 4 centimeter. It is also associated with pain, which was mild and sharp in character, aggravated by chewing food and relieved by relief of its oval. Patient also gives history of difficulty in chewing food. Then there is no history of difficulty in swallowing and speech, no history of excessive salivation, no history of halitosis or bad breath. Patient also underwent some form of surgical treatment in form of tooth extraction for as the tooth were irritating the patient. So 2 years back, he underwent some tooth extraction of our last three upper molars and lower molars. There is also no history of cough, just cough, pneumocolitis and breathlessness. No history of losing of clothes, and there is no history of loss of appetite and
I am still wanting to know something which is typically there in oral malignancy, which you have not told about. No भी बोल दिया, yes भी बोल दिया, तुमने patient has this, he does not complain at all. What are the common symptoms that the patient will come with oral?
No ulcer.
Ulcer, bleeding, pain.
No ulcer.
Then?
Bleeding and pain.
What else?
Neck nodes.
Take a neck node. What else? Chewing tobacco, chewing betel nut for such a long time.
Decrease mouth opening.
So, वो बोलने का है. वो नहीं बोलेंगे तो उनका पता नहीं चले. I don't know if he can open his mouth fully or not. He doesn't have any difficulty in opening mouth or he cannot open mouth. ये बोलने का.
So patient also does not have history of reduced mouth opening.
Continue.
In the past history, patient is a known case of diabetes mellitus for which he is taking regular insulin twice a day. There is no other history of chronic illness. In the personal history, patient is a vegetarian by diet, sleep and appetite is normal, bowel, bladder habits are normal. He is a chronic hookah smoker. He is smoking since last 40 years, 6 to 7 hookahs per day. In the family history is not significant, and patient is not known to allergic to any drugs. And in the surgical history, I mentioned he underwent some tooth extraction 2 years back.
क्या finish? क्या? What is short? Summarize.
55-year-old gentleman who is a chronic tobacco smoker presented to us with non-healing ulcer in the right buccal mucosa since 6 years and underwent some form of.
So, what is most more in smokers, what is more common? Malignancy क्या common है? Smokers. बोल तो यार, बोलना तो पड़ेगा ना। अच्छा, ही हुक्का लेना। इसमें कुछ है क्या? कुछ हुक्के से भी कुछ लेना रहता है कहीं पे, कुछ हो सकता है?
इरिटेशन
किसको?
ओरल कैविटी
पूरी
हुक्का इरिटेट हुक्का इन माउथ
पूरी ओरल कैविटी को इरिटेट करता है।
जैसा बर्निंग
Commonest site. If you
Common
say
site क्या हो?
hookah related malignancy.
कौन साइट क्या है?
पहले
What is hookah?
hookah is some a pipe or in which the coals and mashed leaves, dried leaves of tobacco are placed and burnt and
It is directly taken. हुक्का देखा है? डायरेक्टली जाता है
पिया है?
और क्या होता है? इतने बड़े हुक्के की क्यों जरूरत पड़ी यार? इससे काम हो सकता है।
water.
What? So, it is passed through thinking that it will filter
Filter हो जाएगा।
the impurities. Right? Modern day hookah भी आता है कुछ?
It's a flavored flavored liquid.
कहाँ देख के आए तुम रिसेंटली? देखा है? चलो चलो आगे। Finished? So you think it is malignancy?
The patient is diagnosed case of carcinoma.
How do you know it's diagnosed?
Patient tells that he is diagnosed and underwent some form of treatment.
But he doesn't know. He's been having it for 6 years or 6 years से चल रहा है. You think 6 years of malignancy has been? And he has not taken radiotherapy. How do you know? He has some treatment. What sort of treatment did he have?
Some IV.
What happened after IV treatment? Did he have the IV treatment from a registered medical practitioner or some crack? Did he have in a cancer hospital or a medical college level hospital or at a district level?
He got treated.
In our hospital. So he has been having, so he knows it's chemotherapy. So you can say, patient is saying he has had chemotherapy at an interval of, so if you are very clear about things, you tell him he has had some injection at 21 days interval or 3 weeks or 4 weeks interval, and he was told that this is chemotherapy which is going to reduce this. So then you should have asked him why didn't they operate, or you did not allow them to operate. ठीक है, ये सब clear होना है. 6 years is a long time. So you have to tell exactly why he was not operated. Was he told that it is too advanced? Was he told that, did he refuse it? Or he did not go to a proper place? ठीक है, चलो.
Good morning. Coming to the examination of this case.
Keep it here.
Before doing the examination, the proper consent has been taken, informed consent has been taken from the patient. And the patient has been examined in a proper light, in a privacy. So the patient was from the up to the level of the nipples, and on general physical examination was conscious, oriented, time, place, and person, well hydrated, moderately nourished, and Bernowski score of around 80, with having a vitals with a TP of 120/70 on the right hand lying position. The pulse was around 70 per minute. The patient was clinically capable. The respiratory rate was normal around 70 per minute. Patient doesn't have any clubbing, cyanosis, edema, or icterus or feather, and JVP was not raised. Coming to the local examination in this case.
Hernial sites? hernial side.
That we're discussing is systemic. When you do the local examination, first on inspection, there was a normal facial system, no visible swelling over the face and neck or maxillary, and patient was having their mouth opening of.
Do you do general examination, systemic examination data on, and before that you do local examination, or you, when you are doing taking pulse, BP, everything general exam, no generalized nothing?
एक्चुअली नाउअडेज सर क्या है कि दोनों तरह का सिस्टम है.
ठीक, कंटिन्यू. नहीं, कंटिन्यू, whatever.
On inspection, the mouth opening appears restricted, so the assessment will be done and inter-incisor distance was reduced. Any staining over as seen on the inspection, and there was a visible melanoglytia on the right side anterior aspect of the corticosteroid. And on palpation and findings that I couldn't see any lesion on inspection as such. On inspection, I could not see any lesion except for these findings which I have produced. And on palpation, I found that the inter-incisor distance was around 3 centimeters, around 2 centimeters.
2 centimeters.
2 centimeters. And there is a presence of a melanoglytia on the right cheeks, both upper and lower, and there is a presence of the orodental hymen was poor with a jagged teeth, and there were absence of teeth, both upper and the lower, from the premolar till the last molar on the right side, while the other teeth were normal on the opposite side. In patient, there is a presence of a ulcerative lesion in the right lower GBS, in the last molar extending up to the RMD, with the presence of a around 2 by 2 centimeter in size, with irregular borders and raised edges, and there is a presence of a fibrotic band extending from that ulcerative side towards the upper GBS.
So one thing is clear: the lesion is from lower to upper in RMD.
The lesion is confined in the lower
GBS, so going up to.
There is a whitish band which is being seen.
Only band is.
Now on palpation, it is a band.
It's a 2 by 2 centimeter lesion.
Sir, 2 by 2 centimeter, which is visibly it is exposed, so which I am just about to complete. And the base and the base of the ulcer is the bone is exposed.
4 centimeter बोला था.
I think the patient has received some form of the treatment which has shown some reduction in the size.
This he never mentioned. You should have mentioned because.
हिस्ट्री में भी आएगा ना ये बात.
हाँ, ये हमको समझ में आया कि right from then it is now at this 4 centimeter.
Because patient ये तो बताएगा कि हाँ कम हुआ है. चेहरा तो अंदर देखता है, आपको पता लगा. If you know that I had something there, I regularly watch it, right? So he tell, हाँ it is reduced or not.
The ulcer is not bleeding on touch. It is articulated and fixed to the underlying.
Second thing, in inspection you won't see anything. You tell, I am not able to appreciate.
If the mouth opening was so restricted, it was so deep, but and he already had got a good extraction in the last.
Inter-incisor distance you mentioned 2 centimeters.
But somehow he mentioned it is normal, sir.
It's fine. It doesn't matter. 2 centimeter means like this, around 1 inch.
Yeah, nearly 1 inch.
Approximately.
Yes, the Draco there.
I don't think you don't see RFD in a 2 centimeter opening. You can easily see the RFD.
And it was seen with a great difficulty only, sir. And that's why on inspection I was unable to see. He was having a lot of tremors while I was doing the inspection. But
tremors?
Yes, sir. So, but now on palpation, I just on palpation I was able to do a wooden stick on the opposite side because he was doing it. Because of the pain or the spasm, he was unable to make even the palpation possible. Not possible.
So here you forget to mention I put some local also. Right. If he has pain,
He has pain.
even he tell in history, है ना? बताया था history में.
He has pain.
So you have to examine under some so that you can easily appreciate the treatment. है ना? Like in spray we say 4%. So, add it. If the patient has pain, you are not able to examine properly. Add on. I will examine after putting some spray, local spray, so that he has no pain. ना? Okay.
There is no other lesion palpable or appreciable in any other body subside. There is no the complex skin is normal at the same side with no clinically no negative in the neck. The gag reflex was normal, so cranial essentially examination was essentially.
You want to go to cranial nerve?
Sir, I said with gag reflex in this.
How many cranial nerves are there?
Leave these things. That means.
12. So name from 1 to 12.
Sir, in this case, I will be very specific.
Name 1 to 12.
Leave the things.
तो तुम अगर ये जाना ही है cranial nerve में, तो तुम cranial nerve. तो मैं बैठो पानी पी रहा हूँ, चाय पी रहा हूँ, मेरे को मजे लेने हैं. तुमने cranial को बोला, फट से पकड़ लिया. अब तुम मेंशन करो 1, 2, 3, 4, 12 उनके सारे unnecessarily you are going diverting, है ना?
छोड़ दो, क्योंकि ना कोई इसकी इम्पोर्टेंस है ना कुछ. ठीक है, लीव इट. ठीक है. आरएमटी में भी इतनी डिजीज नहीं उठा है ना. ओनली फाइब्रोटिक पेंडेंट आरएमटी डिजीज इन जीबीएस. कहाँ वो गैप बैक टू द लीव इट.
And on systemic examination and first from the this
हो गया खत्म.
local examination.
और कुछ नहीं करोगे.
Neck is neck.
और कुछ नहीं करोगे.
Sir, along with that, I will go with the big fibrotic laparoscopy.
उसको बोला है ना वो तो इसका पार्ट है ना हेड नेक का. यू हैव टू डू द ऑप्टिक्स करना ही करना. व्हाटएवर इट इज नॉर्मल, इट्स ओके. बट यू से आई हैड किन्स आल्सो. ये ओपीडी प्रोसीजर होता है एंड यू हैव टू सी कि भाई अदर डिजीज कहीं और तो कुछ प्लेट कैंसर आपको कुछ नहीं.
Dr. Pinakin is very rich. He has a Hopkins. I don't have a Hopkins. What will I do?
बताओ क्या कर. अदर टेस्ट यू कैन डू. होता है कुछ.
Indirect laparoscopy would be possible or effect or anything.
Quickly tell me how do you do indirect laparoscopy? Quickly, फटाफट. वो डॉक्टर वो बैठे
Patient consent has been taken. First, the consent needs to be taken.
Okay.
Yes, and patient is being laid in the operating table.
Operating table.
ओपीडी पे करते हैं यार.
Ideal कैसे करते हैं?
ENT वाले.
I will arrange for all these instruments and apparatus. क्या arrange करूँ?
क्या इंस्ट्रूमेंट चाहिए?
I need a proper gauze panel pressure. Along with that, the limousine stay. Along with that, the mirror.
What mirror?
The curve. Mirror.
और क्या चाहिए?
स्टॉक मार्केट में बुल्स एंड बियर्स होते हैं.
बुल्स आई लैम्प नहीं चाहिए क्या यार? इसके बिना कैसे करेगा आइडियल?
छोटी छोटी चीजों पर जाओ
है ना.
चलो.
आइडियल में कितने मिरर्स होते हैं?
बता. प्रणव.
Sir, I need two, sir. One is the examining mirror, then the other is the head mirror, through which the reflected light will be seen.
Reflected light. कैसा होता है head mirror?
Sir, so we have a band which is one across the forehead. On top of it, there is a circular aperture over there. There is a mirror with a hole in the center.
Concave होता है convex होता है?
I think concave.
Convex. कौन बोला convex?
सही बोल.
और तो फिर वो जो लगा के दिखाएंगे ना,
वो बड़ा हो जाएगा.
OPD वाला सारे ब्राइट हो जाएंगे. पेशेंट को
You have to focus the light on the one.
Concave.
So light coming there, you have to focus it, no? If
Pointed
you have a
light.
convex, तो वो light सारे reflect करेगी. So it's a concave.
Draw a diagram. Sir का favorite question.
See, MCh is some basics to our. And this tells that you have gone to the Indian department, that you have done an ideal. If you have not done an ideal, so.
Summarize.
So it's 50-year-old male patient with a previously diagnosed oral cavity malignancy for which he is receiving chemotherapy, presenting with a 2 to 2 centimeter lesion on the left RNT with involvement of the underlying bone without any network metastasis. Patients and no symptom distant metastasis.
And he has one more thing. एक शब्द और बच गया ना, क्या लिया? कीमो लिया ना?
हाँ बताइए सर, पोस्ट कीमो
लिया, फिर क्या हुआ? रेस्पॉन्स क्या बोलेगा? ये भी तो बताओगे?
सर एक्चुअली that depend upon the previous
4 सेंटीमीटर बताया था इसने, डिक्रीज 2 सेंटीमीटर एग्जामिनेशन में आ गया। अब तो कंबाइन तो करोगे ना इन चीज़ों को, पार्शियल जो भी रेस्पॉन्स है वो तो बताना पड़ेगा ना कि रेस्पॉन्स है नहीं है। क्यों? इट विल टेल यू समथिंग एल्स। रेस्पॉन्स नहीं है तो क्या हो गया, रेस्पॉन्स है तो क्या हो गया।
रिस्पॉन्स क्राइटेरिया आना चाहिए।
So the stage will be YC T4A N0 N0. Because the bone is gold.
In gold.
The bone was exposed.
Exposure involvement same होता है क्या?
Sir, actually only superficial cortex involvement. Now I will have to go for the imaging to classify how deep the cortex is involved. But clinically it goes.
Paramandibular soft tissue disease without involvement of the mandible, where you can want to conserve the mandible. So that is main specific investigation.
Or when you want to buy time.
We do. In large, because the mandible is not involved, there is no destruction. Paramandibular large volume disease where you have to do a segmental if you have to start de novo the case, virgin case.
Sir, the resection margins have to be decided on pre-chemotherapy areas or post-chemotherapy?
Post-chemotherapy status here. If you do pre-chemotherapy, then you have to remove the mandible.
That's
Right. So the soft tissue disease is more in comparison. There is no bony invasion. That is the only indication. And there are studies for that also. TMH has done good study in that. Very good local regional response rate in these. Good survival.
Responses were not too high.
Responses were not too high, but they could see mandible. Yes, sir.
Good morning.
Good morning, sir. Good morning, sir. So, regarding the management, sir,
ये क्यों लगा है? ये डिस्कस करना है क्या दिनेश? ये डिस्कस करना है?
नहीं सर, मैनेजमेंट।
अच्छा मैनेजमेंट।
रैंडम क्वेश्चंस का पूछना सर।
अच्छा।
good morning, sir. So, the case is only for post-administration on clinical, on history, sir, it is faster responsive. On already he has done the post-chemotherapy, sir, 6 Now, sir, depending on this, sir, extra country, sir, as well as history, sir, bone is involved. So I will like to, sir, after taking the, after counseling the patient and in the discussing the marketing work, so I will like to go the surgery. Before surgery, I like to counsel the patient, re-evaluate the patient.
See, he has received 4 cycles or 3 cycles. He has received 4 cycles or 3 cycles. 3 cycles. It is partial response. So I feel कि why not to give 6 cycles and wait for complete response. In 3 cycles he has received partial response. 4 centimeter disease has reduced to 2 centimeter. So I would like to ask my colleague give 6 cycles and there will complete response.
Sir, clinically, sir, T4 and T3 and T4 is the base modality is followed by regimen therapy in the form of the RT is the chemotherapy, sir. Because patient has already received, sir, and also patient has already received the TKT. We can also assess this response of chemotherapy in that kind of question.
How will you ask the patient? How will you assess? You have sent the patient to a medical oncologist for chemotherapy. Now, how will you follow up the patient?
Sir, during, sir, after each chemotherapy, before when the patient comes for the next chemotherapy, we like to ask the patient history on history whether the side of ulcer is reducing or not. If there is on physical inflammation, or if there is any edema or skin soft tissue edema, there is increasing or decreasing.
Any new symptom or new nodes he is having or not? Okay. Before every chemotherapy also. Okay. So you say that after 3 partial response have come, now you want to operate upon.
Yes.
Take.
So after proper counseling to patients, and patients should be taken for the pre-rehabilitation therapy. Patients should be asked. Patients should be trained regarding this. Should be reviewing the oral hygiene. There is speech, there is some shallow. When patients should be counseled after therapy, there will be some sort of disfigurement. Patient may have some sort of decrease in this saliva, and there will also this change in the speech and taste sensations.
Speech, swallowing, shoulder functions. 3 things.
Sir, I would like to like some white verification with just segmented as a comprehensive negative with
Who has given this classification of comprehensive neck dissection? Do we use comprehensive neck dissection now? तो पहले होता था, अब क्या क्लासिफिकेशन है? पहले आर्टिकल होता था, क्लासिफिकेशन क्या है? What is the neck dissection classification?
It is a critical injection, modified injection, and selective injection.
Who has given this classification?
What classification do you use?
Sir,
American Association of Head and Neck Surgery.
So we just have to say modified neck dissection, see the level.
Yes, sir. Don't say comprehensive. This word is not used nowadays. It was previously used. So now you say AHNS classification, and this what you said is.
I'm going with the segmental at present, and previously also I was going with segmental.
So what is the fun of giving chemotherapy?
You say you are doing segmental. पहले भी segmental कर रहे थे, तो फिर 4 साइकिल उसका टाइम क्यों वेस्ट किया?
I'll discuss with medical oncologist.
अभी भी erosion है ना mandibular.
Same question as sir asked na, at 3 cycle you found this much response, why not give 6 cycle? है ना? This is the answer. Even after 6 cycle, if you are doing the same thing, what will you achieve? Why waste the time?
But you have at least decreased the soft tissue component in that. Sure.
So I just read somewhere that after 3 cycles, the disease actually starts becoming resistant.
Maximum response is at maximum response is at
Exactly.
Why this happens that maximum response at 3 cycles or 4 cycles? Why maximum response is at 3 cycles or 4 cycles? Manish?
After 3 cycles?
Or 4 cycles. Why this
more than that?
Cancer
is there?
cycles, cell cycle, cancers.
What is anybody here? Why on chemotherapy maximum response is at 3rd or 4th cycle? What is log cell kill?
It's a basic composition model which you are asking, lag phase, log phase and thread phase. So I think वो पूछने बोलने जा रहा है.
Heterogeneity.
So lag phase is the initial period in which the tissues.
No, it's a log cell kill where a certain percentage of cells are killed. Exactly.
Because the cells which are in the different phases that come into a particular phase, that takes time, sir. And the chemotherapy which has a long 50 after, and they X
No.
in that. So the gap between of 3 weeks or 2 weeks which we give in the newborn is that gap in which these things work of comparison.
So the other answer could be that tumors are usually multiclonal. So whatever tumors were to respond to this particular therapy would have been killed in this, and now they suppress the resistant clones.
So log cell, 3 log cell, 4 log cell kill will be 90% kill of the active cells. After that, either stabilizes or increases or remains same or decreases. So maximum response 3 or 4 cycles of kill. Log cell kill should be, So what is the first order kinetics? What order kinetics chemotherapy works, what order kinetics radiation works, and what order kinetics surgery works? Basic. Surgery is 0 order kinetics or first order kinetics? पता नहीं ये छोड़ो अब चलो तुम बाद में तक इसको
चलो आपने
रैंडम क्वेश्चन रैंडम में पूछ लो
Sir, just a doubt. So we will always take the margin. The bone was involved pre-chemo. So we always take the
same resection.
same section.
The only thing is in paramandibular disease where it works and the suprazygomatic infrazygomatic where it works. Otherwise, rest remains the same as pre-chemotherapy excision. Second thing is I'm not happy with your answer of CT scan in this case. I'll be happy with MRI scan. 2 reasons: marrow involvement. Second is nerve involvement, because there is a high chance here. Already you said there is a cortex is breeze. It is seen clearly on clinical examination. So cancer cells might have gone in the marrow and along the nerves also. So I'm happy with the MRI scan, not CT scan in this case.
So what did you say about parameters?
So the extent of disease, only there are 2 conditions where you can decrease this: a large paramandibular soft tissue disease where the bone is not involved. Then you will decrease your resection because the bulk has decreased. Resection will be not same.
What if there was initial skin involvement and then that was
You will take it that, but the bulk will decrease, so that the bulk decreases the skin involvement exactly what is there, you will take that margin. If initially you start surgery with the bulk increase, you will take more skin margin because of the bulk.
So we'll have to estimate what probably
Dude,
how much it was.
compare the two, pre and post. शर्त यह है कि mandible should not be invaded. Only soft tissue bulk disease. What is the blood supply of mandible?
So it is the inferior arteries which is coming from inferior arteries. N arteries.
Okay. Yes. Yes. Blood supply of the mandible. हो गया ना यार? तू थोड़ा relax कर उसको बोलने के लिए.
What comes branches from facial artery?
Branch of facial artery supplies directly to the mandible. Dr. Manish. Maxillary supplying to the mandible how? There is a periosteum capillary network is there, and these are the branches of all arteries around it, like facial, as you said. They all became a capillary. When you do a periosteal dissection, you can see a lot of tributaries running over the surface of periosteum of mandible. So that supplies the outer aspect and the cortex, and the inner part is by the inferior alveolar artery, as you said. So that's why we want to say periosteum if you want to do a conservative resection to decrease the chance of necrosis, osteonecrosis of the mandible. Next. ये देखो क्या है? CT.
is a heterogeneous ciliate in the left artery, extending into the involving the masticator space and right ear. The plates remains in the
Zoom out.
the rector of the thread is normal and the disease of synchrozygomatic. It is extending up to the latent invertebrate, but the plates are free. The ciliate is extending up to the right. Still into the right.
Right side or left side?
Left side. Left. Actually, descriptions are right over, but it is left
वहीं
side.
जाके पॉइंट आउट कर दो
उस पे चले जाओ on the लैपटॉप और हाँ लैपटॉप पे चले जाओ वो एरो से कर दो लैपटॉप पे चले जाओ एरो से एरो चालू करो start right click and see the arrow, stabilize the arrow and then show.
The lesion which is heading into the
This is what?
Upper extension बता रहे थे, ITF बता रहे थे.
heterogeneous lesion is present here. And this black dot is the retrovision red which is green.
Black dot?
This is black line, sir.
Okay.
Yes, sir, this one. So the masticated space and up to the middle vehicle.
So it's a suprazygotic or arch or infra?
Both as a component both.
So it's going up to suprazygote.
Anything beyond this. But here it is not there, but still sir, I'll keep it high. Because middle it is still there. Not that exactly it is there, some bulb fullness, but here it is free, sir. But it is resectable.
Up till the zygomatic arch.
This arch.
Yeah.
This one.
Yeah, go on.
Huh?
One more this side.
There, sir.
It is there or not?
It is there. But disease is there or is it arch?
Disease.
At this level only, sir.
Yes.
It is there. It's a
Up till zygomatic arch.
at the level, yes. But above that, it is. But above that, these films up to here, it is free, sir. Up to here, the disease can be. Plates are normal, so there is no or any extension to the medium or even the neck nodes are not seen in large number of
Right side not too sure.
Random question.
No, because I just want what is this also?
There was some OS and Moreno idea.
There is some technique is there.
On the right side.
There is technique in right side also, but probably that is not the. और क्या है तो अच्छी चीज एक चीज Anything else you find in this old film? कुछ है क्या इसमें? और कुछ किसी को भी दिख रहा है? एक और पीछे नहीं है? इससे पीछे है कुछ और? नहीं एक और पीछे नहीं ये थोड़ी था अभी इससे पहले वो वही वाली थी हाँ ये और कुछ है क्या इसमें? कुछ भी abnormal दिख रहा है इसमें? स्पर है ना यार दिख रहा है नजल का? इंक्यूबेट करोगे ना पड़ जाएगी। ये भी तो ध्यान रखना होता है। तो खाली कैंसर पे कंसंट्रेट मत करो। कहने का मतलब ये है यू हैव टू सी एवरीथिंग बिकॉज यू हैव टू ट्रीट द पेशेंट, है ना। तो इट इज़ नॉट रेस्पॉन्सिबिलिटी ओनली एनेस्थेटिस्ट, इट इज़ योर ओन रेस्पॉन्सिबिलिटी ऑल्सो, है ना। कि आप देखो, वो लोग तो देखते भी नहीं है फिल्म, है ना, बट यू हैव टू सी कहीं कुछ है, यू हैव टू टेल कि प्रोबेबली ही हैज सम डीएनएस एंड सो वी हैव मोर केयरफुल ड्यूरिंग द इंट्यूबेशन।
Thank you. Group C.
Farmer from Jaipur and Ocrober.
नहीं मतलब बिना पढ़े नहीं करता, जस्ट एग्जाम में तो यही होता है।
My case is 6-year-old gentleman, farmer from Jaipur and Ocrober, can complain of pain in the right lower jaw area. Chronic illness, which was apparently asymptomatic 3 months back. Then he started to develop pain in the right jaw area. Pain increases on speaking and mastication, on movement of the jaw, and decrease of the pain mastication. Pain is continuous and moderate to severe, and decrease of the pain medications. Not associated with any trauma or fever or any weight loss. Not associated with any
हिस्ट्री कितनी थी पेन की?
for 3 months.
वेट लॉस नहीं है, ट्रॉमा नहीं है, हेपेटाइटिस भी ठीक ही है, मेस्टिकेशन पे भी पेन है, swallowing पे भी पेन है। इज इट पॉसिबल?
Past, he was diagnosed with the 16th C radicular. For that, he took CTRT. After that, he only taken stop that. So he already stopped that, and since 16, he cannot have further. So no story weight loss. In past history, patient was diagnosed of several things for which we took L2 fraction radiation of 64 weight with concurrent 6 cycle of chemotherapy. After that, you are definitely asymptomatic after that. Personal history, patient was chronic smoker. He used to take smoke 1 bottle per day for around 40 years, but then he stopped after 16. He is vegetarian, non-alcoholic, married, has 3 children. No history of any chronic illness like diabetes, hypertension, chronic CAD or hypothyroidism. Family history, no history of significant family or personal or drug or anything history.
Summarize.
Patient is a cancer survivor of C. oropharynx. So, and complaining with pain in the right jaw, prime suspicion should be any recurrence of the disease.
ये भी कुछ चीज़ है ना, एक वर्ड बस
First thing,
नहीं
left is right side.
अच्छी चल रही है, ओनली पेन इज द कंप्लेन ना, और कुछ भी नहीं है, सिर्फ पेन। क्या लग रहा है, क्या सोच?
Because he is a cancer survivor, so feel radical any second primary of the disease. So they have undertaken the CTRT. but it doesn't have history of trauma, but there may be some body element of the disease or local side of.
तो रिकरेंस या वो तो आ ही गया तो पहली वो तो ठीक है वो सोच.
Does the pain is an early symptom of recurrence or is small? Or pain is an early symptom of any recurrence, or do you see that he is having pain? Why do you suspect that it is a recurrence? Then do you
2016 की disease है.
why do you say that
3 महीने की history है खाली.
pain की history है and he is not giving any history of ulcer over the no, nothing like that. Why you are suspecting?
First, उसी को क्यों? Why not you thinking of those? एक्सट्रैक्शन से जरूरी थोड़ी नहीं दर्द हो. भाई जिसके पहली बार दर्द होता है क्या एक्सट्रैक्शन के बाद ही होता है क्या? समझ रहा मैं क्या कर यहाँ दर्द हो रहा जबड़े में पेन इन द जॉ है ना. सबसे कॉमन कॉज क्या होगा?
Parotitis or something infection, but
means any inflammatory pathology can be there. Why you are suspecting some direct malignancy?
क्योंकि 7 साल का इस गैप है, 3 महीने से ही तो दर्द कर रहा है, तो why not it is tooth carry इसलिए क्यों नहीं हो सकती है?
patient is almost 8 plus, he has only 1 or 2 related to
1 or 2 ही बचे और पेन किस तरह?
on the right side.
तो फिर उसमें क्यों नहीं हो सकता? नहीं, दांत तो बचे. चलो और तो इन्फ्लामेटरी पैथोलॉजी पहले रखते हैं ना, ये गैप बहुत है 3 महीने से दर्द हो रहा है. भाई यही चीज़ें 1-1.5 साल पहले होता फिर देन वी थिंक फर्स्ट ऑफ दिस. नाउ इट इज ओनली 3 months पेन की कंप्लेन है जिसकी वजह से ही इज नॉट एबल टू स्वैलो. व्हाट डू यू टेल मी? स्वैलोइंग का इशू है यही है ना इसका. जब उसके इडेंटुलर से तो मैस्टिकेशन का इशू कहाँ से आ गया ये समझना चाह रहा हूँ. इसीलिए मैंने ये पूछा.
Yes, sir. और
तो रजिस्ट्री में मैस्टिकेशन वर्ड तो जाना चाहिए था उसी टाइम.
क्वेश्चन नहीं पूछ रहा.
What is the pathophysiology of osteoradionecrosis?
Due to radiation, there is endarteration of the vessels and leading to the ischemic necrosis of the ischemia of the jaw. So any transmitting factor can cause the necrosis of so there the osteoblasts are not there, so any trauma.
Why osteoblasts are not there?
After radiation.
Normally osteoblasts are not there, or in this
After radiation exposure.
it is not there.
Endarterectus and fibrosis, osteoblasts are not there. So any
Endarteritis fibrosis is a separate issue. Osteoblasts are not there is a separate issue in osteoradionecrosis.
Osteoradionecrosis, because of the radiation, there is local inflammation and the thrombosis of the end arteries.
That he said was
Because of this ischemia of bone occurs and bone is destroyed.
that is ischemia plus the effect of radiation on osteoclasts and osteoblasts. Both add together to decrease the bone formation in the local side, and because the jaw is the most moving and a lot of pressures are there because of the jaw mastication and all. So those area becomes point for necrosis.
क्या करूँ? Examination.
I have examined patient with verbal consent and presence of attendant proper light exposure and maintaining the privacy. My patient is conscious oriented and cooperative, oriented to translate in person. On general examination, pulse was 78 per minute, BP is 130/80 millimeter of mercury on right arm, and respiratory rate is 16 per minute. Patient is sitting comfortably on bed and gait was normal while walking. And spine examination was normal, and there is no failure, sinuses, icterus, clubbing, or peripheral lymphadenopathy, and serious and CNS examination within normal range.
Only peripheral lymphadenopathy. Peripheral lymphadenopathy, this condition होती है जो specifically. If you mention something, there must be a reason. There might be a central lymphadenopathy and there might be some peripheral lymphadenopathy. You mentioned peripheral lymphadenopathy. Any specific condition, any reason?
For peripheral lymphadenopathy, if there is any infection in lower limb or upper limb, then inguinal or axillary lymphadenopathy.
There is a specific term like peripheral lymphadenopathy and central lymphadenopathy. ऐसा कुछ होता है?
इधर इट इज जनरलाइज वर्ड जरूर होता है या फिर लोकल जिस पार्ट को एग्जामिन करो उससे रिलेटेड
I would like to examine patient with my inspectory findings. On inspection, there is loss of facial symmetry. Typically on right side, loss of wrinkles or forehead, unable to close eye completely. There is obliteration of nasolabial fold, and right side there is the drooping of angle of mouth. On skin, neck and face skin examination, there is a heterogeneously pigmented skin lesions due to the previous radiotherapy, and there is no visible sinus, fissura, or swelling over the neck or face.
Post discharge किधर से आता है?
Sir, he was complaining for post discharge inside the mouth, sir. I would like to confirm on oral cavity examination. There is a 1.5 to 3 centimeter size ulcerative lesion over the right lower jaw involving the buccal mucosa and gingivobuccal circles, extending from the first premolar to the RMD region, and ulcer was margins was ill-defined and edges was reported, and floor was covered with slabs.
posterior extension क्या है?
Sir, RMD. From the first premolar to the RMD.
Lateral.
Laterally, sir, it is involving the buccal mucosa with gingivobuccal circles, sir, and bone is exposed.
There is no scar mark.
Scar mark.
He has been operated. He is not.
No, sir, there is no scar or sinus issue.
What was the previous treatment gone?
Sir, see, he received concurrent chemotherapy with radiation. For oropharyngeal right-sided vesicular apparatus.
So, what from your diagnosis, from your examination, what will you conclude?
Sir, this is likely to with correlate with osteoarthritis analysis.
Straight. पहला डायग्नोसिस, फर्स्ट डायग्नोसिस पीरियड नेक्रोसिस होगा क्या?
और
फर्स्ट यही होता है।
सेकंड
पहला क्या होना चाहिए?
आपने अल्सर बताया, उन्होंने अल्सर नहीं बताया था हिस्ट्री में, तो उन्होंने सिर्फ पेन बताया था, इसलिए फर्स्ट डायग्नोसिस लुकिंग एट द हिस्ट्री वाज इन्फ्लेमेटरी, बट आपने अल्सर भी बताया है, नॉन हीलिंग अल्सर होगा वो।
7 years का गैप है ना, 7 years का गैप है ना आपके, तो समझ रहे हो व्हाट आई एम सेइंग? पहला डायग्नोसिस तो Anybody first time sees osteoradial necrosis schema diagnosis में है possible कभी भी ऐसे ही नहीं
Anybody from his history, examination, can you say something else along with what he's already said? If you're paying attention, he has mentioned something else also in his findings. What? Osteomyelitis findings में बताया और क्या बताया?
He's having complaint on the right sided facial.
Yes.
Facial palsy.
तो वो हिस्ट्री में बताया ना हिस्ट्री में inability to open the mouth, no crease, drooling of saliva. That means facial palsy. So now the whole interview is going to go on to facial palsy.
and if this finding in his examination is there हिस्ट्री में होगी ऐसा तो हो ही नहीं सकता कि मरीज ये नहीं बोलेगी मेरी ऐसी लग रही है ये इतनी चीज ड्रूलिंग एंगल ड्रॉप दिखता है ना तो सामने से
पानी इधर से निकल जाता है पूरा वो आँख में बंद होती है
हिस्ट्री में ये चीज तो फिर लॉस होनी नहीं चाहिए
What is your
बताएगा ये
Actually, there is no drooling of saliva, but there is being
what I am saying it's okay it is not drooling of saliva but simple asymmetry on the face anybody can detect नहीं कोई भी देख के बता देगा तेरा होठ टेढ़ा होता है एनीबडी तो वो पेशेंट की हिस्ट्री में वो पॉइंट तो होना चाहिए
What is your clinical diagnosis?
डायग्नोसिस क्या है क्लिनिकल हो गया ना इन्वेस्टिगेशन बचे हैं खाली एग्जामिनेशन और हिस्ट्री हो गई क्या हो इसे ऑस्टियोरेडियल डायग्नोसिस बोला ना
Non-healing ulcers, with two possibility, might be the malignant one or could be the inflammatory.
देखो
I'm not asking your possible. I'm asking clinical diagnosis.
क्लिनिकल डायग्नोसिस
at the
Clinical diagnosis.
diagnosis can be carcinoma of right lower endometrium, which is going
आप पैथोलॉजी पे क्या जा रहे हो क्लिनिकल डायग्नोसिस बताओ ना यू सेड नॉन हीलिंग अल्सर ऑफ द राइट लोअर एल्वियोलस और जीबीएस व्हाटएवर व्हाट एल्स
with right sided vision.
पैरेसिस पाल्सी पाल्सी है पैरेसिस है व्हाई पैरेसिस व्हाई पाल्सी व्हाई पैरेसिस
Sir, not completely motor function is there, sir. You can go the
व्हाई पाल्सी
Palsy is because there is loss of impulse, inability to close the eyes.
कंप्लीटली
Yes, sir. He is not able to close the eyes.
व्हाट एल्स
So the flattening of the nasal fold, the drooping of the mouth, and he is asking to show his
पैरासिस में एक साथ इतना कुछ कभी नहीं मिला है तो एक चीज़ ही होती है जगह वो भी फुल्ली नहीं हुई ना आपके तीनों कंपोनेंट तीन चीज़ें आ रही है तो नो डाउट पड़ेगा
So your clinical diagnosis is what? Non-healing ulcer of the right lower GBS with facial palsy. This is your clinical diagnosis. Now you will search the cause of all this stuff. How will you investigate?
Sir, I want to add one thing after the starting a systematic first say the facial symmetry, asymmetry, then mouth opening, then dental status, halitosis or not, then OSMF lesions, then other lesions, and then jump into the malignant ulcer. So I'm go directly to the
How will you investigate?
after history physical examination, keeping the diagnosis of a second primary, we are suspecting. We have to first do in blood biochemistry examination, and after taking proper consent, we have to take biopsy from the edge of the ulcerated lesion, which is present on the right lower area. Tissue diagnosis.
Okay.
sir, we have to do orthopentogram of the mandible. When the bone is exposed, we have to look at the features of any posterior process, health of the bone mandible or OPG.
हो गया.
Yes, sir. And if it is after biopsy, it turns out to be malignant, then we have to see the local extent of the disease also, because patient is coming with the history of facial nerve paralysis.
Facial nerve paralysis or UMN type or element type?
UMN or LMN?
Why not UMN?
The opposite
is normal.
अगर बायोप्सी ORN आता है, इन्फ्लेमेटरी चेंजेस आते हैं, then you will go for OPG, है?
As the lesion is sitting on the bone, we have to see the current condition of the bone. So we can see OPG is the easy and
Okay.
बट इसने तो बता दिया ना कि चिप्स पस भी है और चिप्स ऑफ बोन भी बता दिया इसने. बोन एक्सपोज का चिप्स भी बताई नहीं, खाली बोन एक्सपोज है.
आपने OPG करा लिया फिर?
and then keeping an eye on the second primary, we have to PET CT scan also, because the
Second primary दिख रहा है? This one is the second primary, ऐसे?
this one will be a second.
बायोप्सी तो ORN आ रही है ना, इन्फ्लेमेटरी आ रही है, तो फिर क्या कराओगे आप? भाई बायोप्सी तो आपकी इन्फ्लेमेटरी रीजन आ गई, नो मैलिग्नेंसी सी, फिर क्या कराओगे आप?
वो भी
नेगेटिव आ गया, फिर
दोबारा बायोप्सी ले ली, वो भी नेगेटिव आ गई,
फिर क्या करो? व्हाट यू विल नाउ? पहले आप
और कुछ और करवा सकते हैं क्या?
क्यों कराना चाहते हो आप सीटी स्कैन, क्यों कराना चाहते हो? और वेयर प्रीवियस साइट को आप देखोगे या नहीं देखोगे? FOL करोगे या नहीं करोगे? डायरेक्ट ORN है तो सर्जरी करने के लिए ले जाओगे, पता चला वहाँ पे छोटा मोटा कोई लीजन पड़ा है लगी सब, तो सीटी से आप
तीनों चीज़ें दोनों इम्पोर्टेंट है. आपको डायरेक्ट भी देखना पड़ेगा कि छोटा मोटा वो CT स्कैन नहीं बताएगा ना, छोटी मोटी नहीं बताती, वो थिकनिंग बता के छोड़ देगा, वो देखना भी जरूरी है.
फेशियल नर्व का कुछ नहीं करना?
वो भी तो देखो.
Two pathologies you said, na? One here. So facial nerve, कौन सा one investigation you want to do where you can evaluate both of them? So why OPG, then CT, then MRI, then PET scan थोड़ी होता है कोई?
आप अगर स्ट्रेट फॉरवर्ड MRI करा लेते हैं तो आपके ORN भी आ जाता, फेशियल नर्व आ जाती, मेलिग्नेंसी है तो उसका वो जो एक्सटेंशन भी पता लग जाता. ठीक है, स्टिल यू हैव टू डू द डायरेक्ट लेरिंग, उसको भी तो फिर भी करनी पड़ेगी आपको, वो एक अपनी जगह है. इवन वेलिकुला को भी MRI अगर कुछ बड़ा होता तो MRI उसको भी पिकअप कर लेती, सॉफ्ट टिश्यू डिलीनेशन हमें आ जाती. एक MRI में तो सारी चीज़ें कवर हो ही नहीं थी, इतना क्यों घुमा रहा है? नहीं, OPG
You wish to do OPG because it is available, it is OPD.
Just earliest you can get.
Yes,
that is very
But one investigation of choice in this case should be MRI.
फिर आपने जैसे उसमें अंदर भी कुछ नहीं है, there is nothing at vallicula. Biopsy is negative.
क्या करो?
MRI आपने करा लिया है, then
MRI findings are we have to do because patient is having PET CT scans, we have to do the
Whatever you say, give the justification. Simple. जरूरी थोड़ी है कि यार हम सब कुछ जानते हैं, तुम जस्टिफाई करो, हो सकता है.
तो आपने OPG भी कर लिया, CT भी कर लिया, MRI भी कर लिया, आप PET scan कर लो, तो ये तो पूछो क्या करोगे? नहीं कर सकते हैं, कोई दिक्कत नहीं, बट जस्टिफाई
कराएंगे.
हाँ,
जस्टिफिकेशन तो क्यों भाई? प्रीवियसली इज ए केस ऑफ वेलिकुलर मैलिग्नेंसी, ठीक है, ये सब नेगेटिव आ रहा है, मैं सर्जरी के लिए भी जा रहा हूँ, लेकिन स्टिल आई वांट टू सी कहीं डिस्टेंस में कुछ तो नहीं पड़ा. परसेंटेज ऑफ चांसेस इज देयर ना, जब इतना कुछ हो रहा है तो पता लगा कि कहीं कुछ पड़ा है, तुमने या तोड़ फोड़ मचा के बढ़िया सी सर्जरी करी है तो स्टिल ठीक है.
This is the PET CT.
So this is the whole body PET CT image showing axial cuts on axial cut section. Sir, on the third image on the first row, we can see FDG region over the right side of angle or ramus of mandible.
एंगल है या रेवस?
या दोनों नहीं है?
या दोनों नहीं है.
स्टार्टिंग एंगल
एंगल यहाँ पे आता है क्या?
इतना ऊपर आता है, जाइगोमा दिख रहा है यार, दिख रही जाइगोमा, जाइगोमेटिक कोन इतनी थिक दिख रही है तो एंगल होने का तो सवाल ही पैदा नहीं. फुल है ना, या तो रेमस या फिर कॉन्डाइल होगा या उसका कॉर्नर क्रॉस है ना. सो
the rest of the neck and chest imagery lungs are not showing any.
ये मुझे भी ब्रेन में इतना दिख रहा है क्या है?
ब्रेन हर्टिंग इज फिजियोलॉजिकल ब्रेन हार्ट.
अब इसमें कैसे डिफरेंशिएट करोगे कि ये इन्फ्लेमेटरी या मैलिग्नेंट? कर सकते हैं?
We have to put it with the CT images, PET CT images, whether there are lighting lesions in the CT images.
HUV का कुछ हो सकता है? HUV से भी इन्फ्लेमेटरी में क्या रहेगा?
Lower HUV max is lower in
लोअर?
कितना lower? Acute inflammation HUV will be high.
हायर होता है 18, 20, 15 से. आई थिंक आइडियली मोर देन 15 से भी ज़्यादा ही मिलता है अगर इन्फ्लेमेटरी कुछ भी है. इसलिए फिर आप आइडियली नहीं बता सकते कि वास्तव में ये है मैलिग्नेंट, वो बायोप्सी ही बता दें.
Patient is having fever. Does that affect your PET scan?
Fever will be a generalized value of metabolic activity, not really present as other signs. Focal FPG uptake will not be there. Except there is any visible source of infection, then only there will be focal FPG uptake.
Usually, if there is fever, they do not do PET scan, right? And this is a X-ray film showing. This is an X-ray film. Then print. So why don't they give an X-ray film? We'll be able to match and see exactly where on the CT scan. They should give an X-ray film. Yes, no. एक तो प्रिंट देता है, एक उसकी प्लेट देता है सीधे. Why not just give X-ray films so you'll be able to match?
प्रिंट की जरूरत क्या है?
फिल्म की क्या जरूरत है? वो दे देंगे ना, अननेसेसरी प्रिंटिंग.
पैसे
प्रिंट करवाओ, पैसे और हिंट और दे दिया मैंने. सॉफ्ट टिश्यू कंपनी. मैंने क्या हिंट दिया?
कलर.
फालतू कलर पेपर का वो देना पड़ता है.
कलर.
SUV.
You can see the color, now which you cannot see on the film. That is interpretation. So you can see. कलर दिख रहा है. एक्सरे में ये कलर दिखेगा. कलर दिखेगा. अपटेक कलर.
फिल्म होगी ना, फिल्म में कलर नहीं दिखेगा. आप उसको
ब्लैक एंड व्हाइट. ठीक है ना, उसमें कुछ और कलर.
चलो समर्थ, लास्ट क्वेश्चन. आपने now you want to operate upon this patient?
Patient is symptomatic, sir.
What symptomatic? He's saying that there was no pus discharge. He was giving history.
He is very intermittent discharge and pain over the right.
So, do you think that removing that bone segment will relieve his pain?
If it is unhealthy bone, then on CT scan imaging or on PET CT scan there is light lesions, then we have to do that. Otherwise,
Because pus discharge has stopped. He is saying there was no pus discharge. That has stopped.
patient is symptomatic, so patient is having pain and exposed to
Pain over that bone.
and bone is exposed to during mastication also because of friction and pressure. There are chances of necrosis and fracture. Pathological fracture can also get post-dental and necrosis.
And further is not going to heal. So you have to do something. What you will do?
Can you do segmental and mandibular wide excision?
Wide.
Adjacent mucosa also and send it to.
Why you want to unnecessarily remove the soft tissue?
Because there is also a degenerative.
So why wide excision?
Not wide excision, only sir will remove that part and send it for frozen section.
Bone.
Bone will not process.
Frozen section.
के लिए थोड़ी भेजेगा
What frozen section you will say? Unhealthy tissue. Then
If it is not negative, then we can reconstruct with free fibula.
Free fibula?
We can reconstruct with the flap.
what flap? तो वही पे आएगा फिर.
Flap can be a regional flap or free fibula. Free flap.
What free flap?
Free flap. Either sir only soft tissue or we can reconstruct with bone.
Bone reconstruction will take, is it? इतना रेडिएशन लगाइए तो हड्डी टिकी नहीं, दूसरी टिक जाएगी.
So you had taken segment of that, removed that segment and reconstructed it with fibula as you were saying. And in post-operative period, patient is having first discharge. From there, now how will you treat? What is your interpretation for that?
It is justified to do in infected area bone lump.
And what cutting you will take? How much segment you will do? It's not like malignancy you will take. You will say ORM. ORM, you have to take margin. What margin you want to take in these things? Only negative margin.
What negative? You cut the bone and see it as negative margin.
कैसे देखोगे सर्जरी करने के बाद खुला छोड़ दोगे बायोप्सी की रिपोर्ट तो लेट आएगी ना फ्रोजन होता नहीं है तब तक लेट करोगे नेगेटिव आए
समझ रहे? फिर और फिर इन्फेक्टेड में आपने फिबुला और लगा दिया. बस बोल रहे हो और फिर रेडिएशन दे रखे हो. ऑल कॉन्ट्राइंडिकेशंस फॉर ए बोनी रिकंस्ट्रक्शन.
So no bone reconstruction, you need some vascularized tissue. Preferable would be in such a condition, heavily irradiated, smoker, already one side is already gone, you have to cross and bring those vessels if you want to do a free flap. Ideal would be you put a pec major that would also cover the vessels and bring vascularized tissue. No fibula.
How do you assess the vascularity of PMC in post-operative period?
I started looking at the flap quantity, the color of the skin of the flap, and culture, then
और
color,
और
temperature,
और और ऑन टेबल ही देखना है मेरे को एक ही चीज करूँगा ऑन टेबल और कुछ कर सकते हो क्या चलो बताओ और क्या गलत है हो गया यार सब हो गया और बताओ कुछ तुरंत बता देता है इतनी बढ़िया चीज़ है, बेस्ट चीज़ है आज की डेट में तो ICG। इधर तूने इंजेक्ट मारा, इधर बता देता नहीं।
कैसे मालूम चलेगा ICG में कि वेस्कुलराइज्ड है या नहीं? हाउ वुड यू डू इट? प्रोसीजर?
ICG direct injected intravenous after 5 to 10 minutes. 5 minutes it will go to the venue and we can it will blow and hand camera.
कितनी देर तक देख सकते हो?
Up to 3 hours. PR is 3 hours.
3 hours? ना नहीं, आवर्स में तो नहीं है इतना, बट यू कैन इट इज अप टू 30 to 45 मिनट्स तक मेंटेन करता है, इतना रहता है। दिस इज द एडवांटेज ऑफ, इसीलिए 1 ml इंजेक्ट करते हैं। आपको आपने कर दिया, लगा दिया, लगाने में भी टाइम लगता है ना, फिर कहते हैं हाँ यार एक बार 1 ml और डाल दो, अब दोबारा देखना चाहता हूँ मैं वास्कुलरिटी। दिस इज द वे, है ना, ये तरीका है उसमें।
हाउ इज ICG मेटाबोलाइज्ड इन द बॉडी? Through the
ठीक हो गया।
ओपन क्वेश्चन
open session. ओपन सेशन चल रहा है, यू कैन आस्क क्वेश्चन।
फिर वो भी पूछेंगे वो भी पूछेंगे
When you are sitting there. Role of hyperbaric oxygen in this case.
In this case, there is no benefit of hyperbaric oxygen therapy because already devascularized bone and there is a chances of fracture. So there is no role of hyperbaric in this patient unless we are performing a new flap reconstruction with bone graft. Then we can also add hyperbaric oxygen therapy during the healing period.
So what you can say is, you don't want to annoy him now. If he is your examiner, the moment you say there is no role
In these patients.
वो नाराज हो जाएगा, है ना? You can say definitely there is a role of hyperbaric oxygen where the vascularity is compromised or there is no oxygen. But in this case, I do not think it will be of benefit.
कैसे देंगे? How?
Sir, for the healing process, generally 2 to 3 atmosphere pressure with 100% oxygen in the chamber for 30 each session consists of 30 minutes. Yes, sir. Or we can continue 3 sessions per day.
For 30 days.
Long
Post operatively it is given
30 मिनट्स का ही सेशन क्यों होता है? ऐसे क्यों नहीं यार, बिठा दो 1.5 घंटे एक साथ।
With hyperbaric oxygen, there is adverse effect due to the prolonged sessions.
What?
क्या लेकिन मुझे नहीं पता एडवर्स इफेक्ट होगा यार कुछ तो।
Oxygen toxicity is a retinal toxicity.
Ideally, you can set up to I think 45 to 50 minutes ideally, लेकिन 30 मिनट्स की कट ऑफ इसलिए रखी गई है,
Pulmonary toxicity also there.
वेरिएशन लाना ही नहीं है, क्योंकि उसकी जो टॉक्सिसिटीज है ना वो बिल्कुल वही, रेटिना गया, आइज गॉन, पल्मोनरी हो गया तो लंग की प्रॉब्लम, इसीलिए उसको कट ऑफ से बहुत नीचे रखा है।
So related question to this, what happens in deep sea divers or those who go to Kedarnath on a helicopter? Suddenly they go from here to Kedarnath in a helicopter. What can happen? केदारनाथ दर्शन नहीं होंगे और क्या वापस आना पड़ेगा पहले सिंपल What happens to anybody?
You see label as the disease is protocol based disease and nitrogen
So you have to come for HCG.
Yeah.
Too fast.
That is why there is completion chamber, so we have to buy. Chalo. लीजन दिख रहा है कुछ दिख रहा है क्या दिख रहा है
आंखों के अंदर क्या दिख रहा है चैम्बर के अंदर है बाहर है इनसाइड द चैम्बर और आउटसाइड द चैम्बर इनसाइड द चैम्बर क्या है
So what does that mean?
क्या होगा
What is the diagnosis?
बता पूरा तो बता
What is that known as white reflex?
क्या कहते हैं इसको कुछ नाम है इसका
Anyone else? आप लोगों में से
क्या है इसका नाम टर्म है कोई
White reflex. White eye. What is that?
कुछ टर्म है एनीबॉडी
Dog lovers, cat lovers कुछ होता है क्या?
Cat side.
क्या करें
We find out article history of the patient, the family history, and family history is significant or and check if it is if there is no family history, then
क्या फैमिली हिस्ट्री मिली
if there is a history of retinoblastoma in the parents as well, or if it is a new lesion in the child, and then I go for examination, the eye examination, the vision.
क्या
The light, the child can see, and the level of visual acuity,
मैनेजमेंट
and the other eye is important. The
दोनों
other eye.
एग्जामिन दैट मैनेज करो
If there is no vision in the eye,
आता है क्या नहीं पास कर दो तो आगे पास कर दो कोई बात नहीं
For retinoblastoma, well, we have to go two therapies are there. One is the chemotherapy and one is the surgery. Chemotherapy we can consider the actinomycin D, Interstate, and retin. In the form of surgery, we can go for a inhibition.
इसका
For chemotherapy, you want to go for biopsy or FNS in this patient? So, on clinical diagnosis, if needed, you will send patient for chemotherapy.
Yes. Without biopsy, we can go send for it.
Why no biopsy?
We don't want to consider this tumor chances of the spread.
Vision loss. Plus, this is the only diagnosis that is made with this disease. So it's a diagnostic characteristic.
Any comment?
What is the response rate of retinoblastoma by chemotherapy? Response rate. Chemotherapy. It's curable, not curable.
With chemotherapy, this patient will need surgery or not?
child is required.
If you are given chemotherapy to this patient, still you will send this patient for chemotherapy surgery or not?
Surgery we have to go for definitely.
This marking has been done to confuse you. Don't worry about the marking.
There is a lesion which is visualized on the volar aspect of the distal aspect, distal 1/3 of the forearm.
Left arm, right arm.
Left side of the left forearm. Which appears to be
Volar aspect, dorsal aspect. This is dorsal aspect or volar aspect?
dorsal aspect.
Dorsal aspect.
और क्या दिख रहा है? That's right.
But there appears to be an ulcer on the stomach of the lesion as well.
What?
How will I stage it for?
Could it just be an abscess? Hello. एक चेयर ले लो। चेयर।
It appears to be unlikely to be an abscess.
So what will you want to do?
Sir, I would start by with the history and physical examination.
So I would like to know more about this patient.
Yes, sir. Like to examine the patient, one joint above, one joint below as well. Examine the patient completely, see for any other satellite lesions or multiple lesions, joint movement, vascularity. Like to examine all of those, sir. And then start off.
बस vascularity है, one joint above और कुछ नहीं बोला जो कि important था.
X-rays.
What else? X-ray examination.
Neural examination.
Neural हो गया, vascular हो गया, और artery के बाद vein के बाद nerve हो गए, bone हो गए, और जो most important है वो तो भूल गए.
मूवमेंट भी देखोगे क्या इसमें काम कर रहा है नहीं कर रहा है
One joint हो गया, और ये सोच सर्टन के लिम्फ में तो जाएगा ही नहीं, तो लिम्फ नोड्स एग्जामिन नहीं करें.
Which group of lymph node you want to see?
So the axillary.
Epitrochlear.
Epitrochlear and the axillary nodes.
In historical terms, if the epitrochlear was present, what did it mean?
अरे सही कह रहा है यार तो कंफ्यूज हो सिंपलिस ही होता था पहले ही
So this is the image.
This is a coronal, sagittal or axial cut of CT scan or what?
CT or MR?
MR is
ठीक है आगे
Coronal. Coronal cut, sagittal cut.
the axillary cut. T2-weighted axial cut of an MRI which shows the soft tissue mass which is predominantly present over the lateral aspect. Predominantly present over the dorsal aspect shows a hyperintense mass which is present involving the dorsal compartment with sparing of the bones.
चलना कौन सी है, रेडियस कौन सी? दैट इज चलना, और ये रेडियस है का। बताओ क्या करो?
First step after the MRI, we would first investigation would be a biopsy, sir. Should be done by a trained surgical oncologist or someone who specializes in soft tissue sarcoma. A core needle biopsy, sir. A core needle biopsy should be taken predominantly, preferably in the same line which will be there in the picture surgical. After the biopsy, one part 4-cut biopsy and another is 2-cut biopsy. What is the name of the instrument, sir? Core needle is the actual. Core is proper. Core is the proper one. What is the name of the instrument? The brand of the brand of the.
We were taken biopsy, came out the sign of the.
Depending on the size, if it's an extremity sarcoma, so depending on the size, if it's less than 5 cm, I could go for upfront surgeries. But if it's between 5 or
क्या करोगे? क्या करना चाहोगे?
so ideally we should go for a function sparing complete surgical excision. So if that is possible for this patient, I will go ahead with an upfront surgery if it is less than 5 cm.
Suppose it is involving the vessels and it is less than 5 centimeters, then again you would go for upfront surgery.
If function sparing surgery is not possible, I will go ahead with neurosurgery.
What is important is to see the neurovascular,
Yes, sir.
irrespective of the size, what is more important?
Neurovascular involvement, whether the limb can be spared or not.
Oh.
So if that is possible, upfront surgery can be considered.
Oh.
Other than that, even if function sparing surgery is possible upfront, but the size is more than 5, I will prefer neoadjuvant chemotherapy. Then on the basis of that, on the margins, I will consider either post-operative IMRT or intraoperative radiotherapy.
नहीं है, इन्वॉल्वमेंट सा है, सब देयर इज न्यूरोवास्कुलर इन्वॉल्वमेंट लग रहा है. नाउ व्हाट यू विल डू?
Neoadjuvant chemotherapy देंगे सर, with ifosfamide, daptomycin and mesna, either the main or the cyclic regimen. One of these two I will be giving sir. The basis of it, and then I will, after neoadjuvant chemotherapy, I will go ahead with function sparing surgery.
Still you are not able to get the margins after neoadjuvant.
So if margin is not able to get more than 1 centimeter, it's either R1 or less
Bone
than 1
involvement is there.
then I will have to go ahead with an application. If it's not possible, even after neoadjuvant chemotherapy, if I'm not able to spare the limb, then you will have to go ahead with the application. Ideally, more than 1 centimeter. More than 1 centimeter margin must be.
Is an achieved on
Where? 1 centimeter margin where?
Where?
Wrist.
ट्यूमर कहाँ है? देखा तुमने?
Any facial clearance is sufficient if it is not involved. There is no indication of 1 centimeter margin.
In case of bone, etc., periosteum will submit as a good margin, so that contributes. But in case of soft tissue, if we can resect the ulna appears to be uninvolved, so we should be able to get a good margin over there. In case of the radius, instead of compromising the bone, we could resect it with the periosteum as well.
No, here. In this case.
Yes, sir.
What do you want to do? Amputation?
Chemotherapy. I asked if neurovascular bundle or.
So there is a qualitative margin here. Important.
Yes, sir.
Because 1 centimeter is okay, but in soft tissue tumors, it is near the vascular structure. So you have to take the only qualitative margin. So quantitative margin is not possible here. So this much tumor if you remove, the compartment muscles are also gone. 100% gone. This dorsal compartment is gone. This tendon, everything is gone. Now what will you do? फंक्शन के बारे में कुछ सोचोगे?
Tendon transfer, you can plan to the extensor tendon must be reimplanted to facilitate.
How will you do it? All the extensions are involved. You have to take a margin. There will be a gap of approximately 10 centimeter between tendons, cut the end of the tendons.
TFL transfer chemicals, that's a visual
So that you have to discuss with the plastic surgeon.
Yes.
You discuss with them whether it can be done or not. What about vascular?
Sir, post-normal chemotherapy as well, that still appears to be vascular reconstruction. We can consider the vascular reconstruction along with dissection. With the help of the plastic surgeon.
Nerves can be done.
Nerves can also be done.
Then why you give me chemotherapy? Why not straightforward go for that?
So this would increase the complexity of the surgery, sir. If you can do it without having to do this, that would be better for the patient.
What is the gain of if you put a nerve transfer there? है ना? Functional assessment का क्या system रहता है? How much time it take? कितना grow होता है nerve का system क्या पता है? Growth
0.1 mm per day.
So it will take the length of the segment you remove. That will important.
Won't you give RT to this patient after surgery?
Yes, sir.
Then what will happen to the graft, neural graft? You want to delay it till 2 months?
क्या ग्राफ्ट लगाओगे? चलो पहले ये बताओ. Options क्या क्या हैं?
Sir, if it is only soft tissue for tendons, we can be doing it.
टेंडन कर दिए वो तो परमानेंट काम है, उसको तो छोड़.
And for soft tissue cover, we can.
कवर तो देना ही है ना?
हाँ सर, देना है.
क्या क्या ले सकते? ठीक है. और मेरे को नहीं आता.
Intraosseous artery based flaps can be done, sir.
Osseous कौन से आ गया?
Intraosseous artery.
अच्छा, intraosseous.
हाँ, intraosseous artery based rotation flaps can be done.
ठीक है. लगा पाए? सीवर भी है इसके. और बहुत सिंपल चीज पूछना चाह रहा हूँ. मुझे क्या आता है बता. मैं तो नया SSG टेंडर पे टिकेगा कभी? इतना तुमने एक्सपोज कर रखा है. हाँ क्या मतलब है? सही है. मुझे वही आता है.
या फिर कुछ और
नाम सबसे इजी है. इनवाइनो फ्लैप लगाते हैं. अपने लिए सबसे सिंपल वही है. जस्ट रेज इट एंड पुट एयर. हैंड विल बी अटैच फॉर एयर एटलीस्ट. बट इट्स फाइन.
इसमें अंदर कंटिन्यू.
कैसे? और
all black lesions are melanoma, sir.
We should, any ulcer, blood, we should have been.
आंसर कहाँ है? आंसर है? आंसर तो नहीं दिख रहा है यार. तो फिर ब्लैक ही है ना?
But we should be suspicious.
नहीं वो मान लिया तो सस्पिशियस है.
It's a single pattern of black or they are different shades?
फीचर्स बताओ ना आपके. What I am asking, what is the feature you think it is?
It's a elevated or it's a macular or something else?
मैं तो वरना फिर मोल लेके चला जाऊँ. क्यों जबरदस्ती ऑपरेट करे? तड़तनी क्यों परेशान करूँ मरीज को? हिस्ट्री ऑल्सो इज इम्पोर्टेंट. कितने टाइम से है ना? टाइम पीरियड इज ऑल्सो इम्पोर्टेंट. वो क्या है दूसरा?
Satellite laser. Satellite laser.
क्या हो सकता है? See, you have to tell whatever it is and what you say justify that.
So you are thinking it's a melanoma?
क्या करो?
I will do a biopsy operation. I will take a deep biopsy. And then to take.
Biopsy? Exercise?
Yes, they need to take it. another you need to take pneumocogenital. So if you that is then you need to take morphine and cardiac.
If you see this, क्या size होगी इसकी? Less than?
Size is not a matter.
नहीं, मैं कुछ और पूछना चाहता हूँ। मेरी बायोप्सी ले होगी आप? बायोप्सी क्या है?
Yes, sir, we need to biopsy.
कौन सा biopsy?
Sir, actually, sir, we need to access both the lesions. We need to find out and need to take completely sir. We need to take envelope.
बायोप्सी कहलाएगी क्या? एनब्लॉक पहले डिसाइड कर बायोप्सी कैसे चला एनब्लॉक।
पहले बायोप्सी के बाद
तो बायोप्सी क्या करेंगे ये पूछ रहे हैं, उस पर रहने तो बाकी बात कर देंगे।
So in case of melanoma, we need to take a deeper biopsy because we need to know the depth of invasion.
कैसे लोग?
Each biopsy, but we need to take a deep.
कुछ और इंस्ट्रूमेंट आता है जिससे बायोप्सी?
Actually, this instrument in ophthalmology department where you can take a deep pulse biopsy.
तो ये डर्मेटो
मामला होता है वो। ठीक है, ले ली आगे। अब
Then I see the depth of depending on the depth of information, I need to take the transfer the hospital service.
क्या फ्लैप लगाए? वो भी काटना है, जरा को सैटेलाइट बताना। और इधर भी एक ऐसा दिख रहा है, पता नहीं है नहीं। ठीक है, क्या लगाओगे इसमें? एक्सरसाइज करोगे, वाइड करोगे?
पूरा में कट
So depth is 2 mm, that is very how so 2 centimeter margin I take.
2 सेंटीमीटर तरफ क्या अब
रिकंस्ट्रक्शन कैसे?
भाई तुम यहाँ से जाने के बाद सर्जरी तो करोगे, कम से कम वो तो पता होगा ना। वो भी फोन करके पूछेगा सर को, सर इतना है क्या करना है काटने के बाद, बता।
डॉक्टर मनीष के पास रहते हैं।
क्या हो सकता है? चलो क्या क्या ऑप्शन है? चलो
फ्लैप लगाएंगे फिर कैसे करोगे?
Actually, you can protect the medial aspect of
ऑप्शंस पूछ रहा हूँ तेरे से, तू श्योर छोड़ दे भाई। क्या क्या हो सकता है यहाँ? ये तो पता हो, ये तो पढ़ा होता है ना, ये तो बताया ना क्या क्या लग सकता है। मैं ये थोड़ी करूँ तुम क्या करोगे, छोड़ दो उसको। क्या क्या हो सकता है? अरे क्यों श्योर नहीं है यार? क्या क्या हो सकता है? कितनी सिंपल सी चीज पूछी मैंने। सबसे सिंपल क्या होगा? चलो, अरे एसएसजी नहीं लगा सकता क्या? नहीं लगा सकते? वेट बियरिंग नहीं लगा सकते। ठीक है, अब लोकल क्या लगाया?
कौन सा रोटेशन?
रोटेशन फ्लैप मेडिकल डी आया बेटा, रोटेशन तो आ ही नहीं सकता कोई। कहाँ पर है देख?
पहुंचेगा
यहाँ तक पहुँचेगा ही नहीं ना। मीडियल प्लांटर नहीं आ सकता नहीं। ये अवेयर हो जाए ना अभी ये चीज़ हाँ, दैट्स मीडियल प्लांटर उठाया रिवर्स जाएगा, ये रिवर्स जाएगा। इसकी जो सप्लाई होगी ना दैट इज फ्रॉम डिस्टल पार्ट से आएगा। हाँ, ये डिस्टल से आएगा, सो यू हैव टू चेक फिर। और क्या करोगे? आपने एक्सरसाइज कर दिया और अब
Sir, actually we need to see whether the same brands and those are specific exams. We need to see
कैसे पता करोगे कि बीच में कोई लोड है नहीं है कोई टेक्निक? कितना पढ़ते हो तुम यार? लिम्फोसिंटिग्राफी कितनी बार करी? यहाँ क्या कर सकता है? क्या कर सकता है? तुम कितना कॉमनली करते हो यार, क्यों नहीं होता यार? कितना पढ़ते हो एक दिन, मतलब अरे आजकल तो लड़ाई चीज। सेंटिनल नाम की कोई चीज ही गायब कर दी है? नहीं हो सकता। ये अंदर लिम्फोसिंटिग्राफी अच्छा उसने पहले बोला था सेंटिनल तो यही मैंने एक्चुअली सॉरी मैंने सुना नहीं सेंटिनल करोगे ना अब वो सेंटिनल में पता लगा कि लिम्फ नोड आ रहे हैं ये यहाँ पर है यहाँ पर है यहाँ पर है क्या करो मतलब वन इज इन द लैग वन इज इन कॉम्बिनेशन देन इन इक्वाइलल देन देयर इज नथिंग व्हाट विल यू डू हाँ आ रहा
if it's the completely neural region, then we can do completely in the neural region का both the same.
but if there is a lag and high also then what will you do
Synchronizing processor.
क्या करो मैं वही पूछ रहा हूँ then what will your plan ना lymph nodes की बात है if there are nodes even in lag in thigh सर्जरी नहीं करोगे because if you remove all of them है ना there is 100% lymphedema 100% there is a lymphedema it is not possible है ना नहीं करना सैटेलाइट इज ए डिफरेंट थिंग और नोडल इज ए डिफरेंट थिंग आपने नोडल जो है वो अलग चीज आपके इतने सारे नोड्स हैं पूरे पाँव में नोड आ रहे हैं सबको कैसे निकालोगे इफ यू रिमूव ना तो आप पूरा जस्टिफाई कर दोगे ना बट आपने डस्ट इतनी जगहों पे अगर एक्सरसाइज करोगे तो योर लिम्फेटिक सिस्टम विल डस्ट एंड दैट विल 100% लिम्फेडिमा इज देयर और जो लिम्फेडिमा होगा वो अलग हुआ वो अलग चीज आई है आइसोलेटेड लिम्फ पर
एक्स्ट्रोवर्ट्स मेलानोमा कहाँ से अराइज होता है? What are the other structures which are derived from the neural crest? कहाँ का न्यूरल crest का टिश्यू होता है? और
sympathetic nervous system. Meninges, mucosa.
इधर कुछ होता है? इधर कुछ होता है? फिंगर में?
क्या है यहाँ लोग? लोमस 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 एक चीज़ होता है मेरे को है ना फ्लैप लगाना नहीं आता मैं पेरीफेरी में बैठा हूँ और ये पेशेंट कहीं जा इज नॉट एबल टू मूव है ना बट एक्सरसाइज करना ज़रूरी है मैं तो SSG ही लगा पाऊँगा मैंने लगाया अब क्या करें नहीं नहीं वो वाला SSG लगाएंगे क्या
सेम मेलानोमा पेशेंट
वही था मैंने SSG लगाया क्या करो अब क्या केयर करनी है कैसे करो होल्ड कर दो इवन यू कैन यूज द क्या कहते हैं रबर चप्पल्स आती है ना ठीक उसमें होल कर दो सोल का होल कर दो एंड इट कैन बी डन ऑफलोडिंग जो होती है ना ऑफलोडिंग का तो है ना पहले करते भी थे ऐसा नहीं लैब तो हुआ है पहले तो नहीं करते
ये सभी के लिए है
सपोजिंग उसका एम्पुटेशन कर दिया so what can you do after the amputation? Supposing you have done an amputation, you can give a artificial prosthesis. What is available here? Jaipur leg. उसको नोबेल प्राइज मिल जाएगा
वर्ल्ड फेमस है
जयपुर
सर का नाम क्या था
This case.
देख लिया फर्स्ट नाउ सेकंड What is this procedure?
Production of plastic.
run up class.
What is benefit of this?
So you get the mobility of the knees and
So your
hospitality
ankle will work as
knee.
हमारे बॉस थे उन्होंने किया था
Some more next.
सर फोटो
और उसके बाद में
दो बजे से सर
पैथोलॉजी सो कहाँ करनी है?
वो यहीं पर
यहीं पे करनी है। फोटोग्राफर तो चलो
ये सर ये वर्क फॉर इमेजिंग कोऑपरेटिव प्रोसीजर वो यार अरे यार
बाहर So there is a true card which has a knife at the end and visiport which you can keep going directly with that. It cuts and then you are seeing that and you are getting the image and you can go inside. किसी ने देखा नहीं? Visiport ही बोलते हैं. That is what I am saying. Visiport.
एक चेक उठा कोई सब
Atlas trial. Atlas trial.
Atlas trial.
Atlas.
You had your lunch. आवाज क्यों नहीं निकल रही है?
Sir, Atlas trial is adjuvant tamoxifen long against short course treatment, sir. It is a trial for hormone positive breast cancer. That 5 years cases 10 years. And we are giving how much is survival and the disease-free survival was checked, sir. Disease-free survival and the OS survival was better when we give 5 years survival and opposite breast disease and the same breast recurrence was comparatively less compared with the placebo.
I have not understood what you are trying.
The comparison of the person in a controlled environment.
It is a study to validate or you can definition देख लेना what trial means. It might be for something new, it might be for revalidation of something. And then you must know everything. Control वो है, randomized क्या है, double blind क्या है, cohort study क्या है, all those things. ऊपर पीछे देखो. You can sit down. ये लाइट आगे की तरफ Mike.
Sir, I'm able to see the lesion in the left side of the lung, sir. I need to see the floor.
Okay. This is what you are saying. What else? But just show me what else you saw. The pictures these people are prompting liver. There is nothing in the liver. What is this? See this ऊपर एक है with peripheral halo. Go further down.
Okay, just नींद आ जाएगी. लोग इसका मिशन का कौन सा वाला और
Multiple level missions also there, sir.
Operations नहीं देखो.
सर वो आएगा.
अच्छा चलो. Next.
Roll number 2.
Das.
Das ist doch der last specimen.
Pick up. आगे रखो. आगे खसका पड़ता.
Rotate.
फ्लूइड गिर जाएगा नीचे. देख लिया.
Not this guy.
Take the mic.
This is a 4-valent Higgs carbon specimen of sir, large bowel sir. Showing sir, there is a
Transverse colon, cecum, ascending colon, descending colon, sigmoid.
most likely sir, ascending colon sir.
Ascending colon.
I'm not sure sir because I have not seen any sir evidence of the small bowel.
इधर turn करो.
Then must know.
Ascending colon.
लेकिन सर वो नहीं है.
एक दंगल रखो.
सबसे नीचे क्या है?
Scale नहीं है. Scale नहीं है क्या?
अच्छा है ना?
कोई नहीं.
हाँ.
नहीं ये trauma there.
Sir, I must say colon.
Colon?
जी जंक्शन नहीं दिख रहा तुमने
डॉक्टर दिनेश तुमने बताया नहीं यार ये बेसमेंट तो बता देते हाँ बेसमेंट तो बड़ा नाक कटाएगा ये लड़के क्या है ये
एक्सीडेंट से क्या
ये सर जी नहीं
ये ऐसे करेंगे तो कैसे काम
ह्यूमन का है गोट का है
ह्यूमन का
एक्सीडेंट देखो ना क्या सब दिख रहा है क्या
नहीं सर then when it will be sir become with the junction in the similar stomach and sir the
स्टमक मैंने गलती से बोल दिया मोहिंदर
रूबीज कैसे होते हैं स्टमक में?
stomach में sir longitudinal होता है
हैं?
longitudinal
कैसे?
canvas है
sir
this is the specimen of rectum ध्यान
बस जाओ वापस
हम आ गए नीचे देख क्या है सबसे नीचे
दैट इज नॉट स्किन एनल कैनाल काला काला
काला स्किन नहीं दिखी तुम्हें तो क्या हो गया
sir specimen of sir appears abdominal
When you are doing an anti-recession or APR, what are the 5 sites where you damage the nerve? And which nerve I'm talking about?
Sir, at the origin of sir IMA sir, there may at the origin of IMA sir, information the library. There may be sir injury to the hypoglycemic nerves.
आपके दूसरे nerves there. वहाँ पे IMA pathways nerves कहाँ से आती है?
What is sir? It will divide with programs.
Relax, please. IMA पे hypoglycemic nerve कहाँ से?
Hypoglycemic plexus.
Hypoglossal plexus तो कुछ होता ही नहीं.
Hypoglycemic plexus.
Hypogastric plexus. Which one? Which hypogastric plexus we are talking about?
Superior plexus.
Superior hypogastric is तो hand level पे नहीं होता, नीचे होता है. Bifurcation नहीं होता. IMA level पे क्या होता है? And how to avoid those injuries during surgery?
Sir, the IMA to be sir ligated, so to be ligated sir. IMA ligated should be high sir. High ligation should be done.
High ligation को damage ज़्यादा होगा कम होगा?
नहीं कम होगा.
ज़्यादा होगा. Towards more towards the aorta, more complications of neural injury.
Now it's a specimen.
Towards the specimens. What else?
It may also sir
2 sides होता है, 5 sides होता है यहाँ.
It is also it may induce sir at the sir both the side of the pelvis sir, when it becomes hip fracture.
There are hypogastric nerves along the lateral pelvic wall.
It may induce when it the lateral plexus or when it branches of the vesicles of the blood that implement.
What is that? The inferior hypogastric plexus. And fifth, when you are doing posterior dissection on the sacrum, so indications of this surgery.
Sir, indications for surgery, sir. One is patients having sir cancer of the sir or anal canal. When sir after
Cancer of the
anal canal sir. When it is
anal canal.
When it is sir.
See, what you are using is cancer of anal canal. Lymphoma of anal canal है, तो आप करोगे. Small cell carcinoma है, तो indication होता है कि
Adenocarcinoma of the anal canal. After sir giving sir definitive superiority, if there is a residual disease, one is indication sir. After sir, in cases of sir low line rectal cancer, after giving the superiority, if there is external sphincter involvement, and when it is cannot be preserved, then it also shows indications.
It is extra related.
Sir, when this low-lying rectal cancer, when it's involved with the liver, when it cannot be saved, then sir, we have to take the extra level.
Check. Instrument. Organ तो दिया हुआ है. क्या है?
Sir, ribs better excmeter is.
Excmeter पूरा नाम बताओ.
Ribs better excmeter, approximator.
क्या? नाम क्या है?
Phenocyte.
This
in thoracic surgery, sir, when the thorax has to open, sir.
When thoracic surgery.
When
Name of these parts.
This is the two, I don't know exactly, but this is the two main spaters, sir, and this is the regulator, sir, where it can, when it is
a short shaft there.
Short shaft, and two short shaft, one is long base, and with this regulatory handle, it can adjust this, adjust and fix the openings.
Why it is fenestrated?
Isn't it?
Why it is fenestrated?
So that it can be locked, sir.
No, this fenestrations are why it is fenestrated?
So the lung tissue, there is less chance of trauma.
To decrease the trauma, make the instrument lighter.
Lighter.
What is the metal used?
Stainless steel, sir.
How do you sterilize it?
The autoclave, sir.
Autoclave.
Yes.
What is the commonest injury that occurs with this?
The nerve that is along this lower edge of the rib can be, sir.
You can classify the injury to the patient and injury to the surgeon.
Yes, sir.
So I want to know what is the injury to the surgeon.
So if it's during the use of the instrument, sometimes it's enter the fingers.
Invariably your glove or finger might get injured. So you have to be very careful when you do it.
RPN in this. RPN in this. Sir, following sir this testicular tumor, this non-centimeter germ-specific tumor, after giving the chemotherapy, if there is a residual disease more than 1 centimeter, and there is high, this tumor marker is negative, sir. That is one of the indication of this RPL.
Name the various templates of RPL.
The standard template is it is bounded superiorly to put on the renal vessel.
Name the templates of RPL. Bounded.
Sir, right side is from the right sided extension from the right renal vessel up to the template is right to left template.
What is the difference between nerve sparing and nerve
nerve sparing RPL in this, this refracted, which is the most common combination for the refracted ejaculation, it is not happen. So it is preferable in the young patients.
Difference, yeah.
In
Now
the
dissecting is not sparing.
this is not this not replaces spares.
How?
By
दोनों में now spare कर रहे हैं.
स्पेयर दोनों में हो रही है, एक स्पेयरिंग है, एक डिसेक्टिंग। क्या डिफरेंस?
Technique indications.
Sir, by this is a split and roll technique.
कब कौन सा करेंगे? नॉट डिसेक्टिंग कब करेंगे?
So when this residual this lymph node is engaged in the nerve and without segmenting the nerve, the articulation cannot be completed. Then we will do it.
स्पेयरिंग में कैसे क्या करता है? तो टेक्निक में
Sir, what happened is Hanagava and this aorta has to be cleared, sir. Circumferentially, sir.
Terminology का classical nerve sparing nerve dissecting. ये terminology.
आप बिल्कुल उसके उस लेयर तक, अगर डिजीज इतनी ज़्यादा नहीं है तो आप ऊपर से उस लेयर के ऊपर से निकल गए, नर्व का पार्ट उसके गए ही नहीं है। हाँ, डिजीज ज़्यादा है, लिम्फोड्स है, उधर जाना पड़ रहा है, देन यू हैव डिसेक्टेड। दैट्स द वे। डैमेज होने की संभावना किसमें ज़्यादा है?
This is the most residual disease ज़्यादा होता है।
मैंने क्या क्वेश्चन किया?
Amongst the three, सबसे ज़्यादा damage कौन से
full template में?
टेम्पलेट तो स्पेयर हो गया ना, क्लासिकल में
ही होगा ना, क्लासिकल में तो बस आपको
काट रहा है,
काटना ही है।
you cannot save nerves. Why you cannot save nerves? Because of massive nodal mass. That is classical. Classical में you bear everything, cutting all the nerves. Templates are saving. You save, template of principle क्या है? What is the principle of nerves templates? Of our
So these, according to the site of the tumor, sir, the landing will be defined, sir, right or left. And this, according to this, sir, this tumor burden may be, sir.
बेसिक क्या है इसका? राइट या लेफ्ट कर रहे हो तो ठीक है, समझ में आ गया, लेकिन क्यों एक तरफ का छोड़ देते हैं? क्या है?
Basic principle क्या है? So that this one side of nut can be bigger.
Why?
So, कितनी नर्व होती है? एक इधर से आती है, एक इधर से आती है, तो इससे क्या फायदा हुआ?
This elimination of anastomosis between the two lymphatic drainage. More concepts are the lymphocyte and in the pilot.
So in N0, most or small palpable discrete nodes, only these conservative RPLNDs are done in residual status, right? So you save those lymphatics and neural plexuses which are not involved, opposite side. So template for right is separate and for template for the left is totally separate. Because the lymphatic drainage from right side goes in different way and the left side goes in different way in early lymph node metastasis, right?
Sir, can you please repeat one?
तुम आओ ना तो पूछो, मैं तो कोई क्वेश्चन माइक पे बात करेंगे नेक्स्ट। बोलो नेक्स्ट क्या है? वो चेक करो रेडियोलॉजी।
आगे आ जाओ। टाइम ज़्यादा
माइक लगाओ।
चाय से पहले आधे लोग
There will be some stimulated areas that I will show you.
Stimulated area where?
Maybe sir.
Maybe नहीं तो है जो पता नहीं
इसमें मे और W कहाँ से आएगा यार?
है तो है नहीं है तो नहीं
हाँ। क्या नहीं है? तो क्या है जो दिख रहा है जो तुम्हें स्टिमुलेटेड जैसा लगा?
Sir, there is it may maybe sir needle sir because it is the needle.
Okay. What else?
It is a moderately dangerous vessel. You will see any sir microcation.
So, are you happy with this mammogram?
I like to see the one is
ये कंप्लीट है क्या ये?
Why?
because this technology is not
Vectorized measure in CCV is seen. Vectorized measure is seen in CC view. CLOV कौन सा होता है यार? There's no CLOV. He's in hyperglycemia and always sleepy. CLOV नहीं होता है, MLOV होता है यार. तो CC view में do you think this is a sufficient? I mean,
क्या
is it okay?
What do you want to see in this?
What else you want?
नीचे ऊपर कुछ देखना है?
पेट्रोल कहाँ से आ गया बीच में यार? वो MLO में आता है. ऐसे बात करो.
ऊपर या नीचे?
See why this is incomplete mammogram ये बता दे. Is it a complete or not? Yes, no. Why? No whispering. Because there is no opposite mammogram to compare. So how will you know there is a lesion or not? To CCV opposite mammogram breast I want for this to make it a complete mammogram. Right? ऐसे बोलना पड़ेगा आपको. Then second thing, to locate the lesion also I want MLO view. ठीक है?
जितनी लाइनें तुम बोलोगे उतनी लाइनें कम क्वेश्चन.
You should know all these. चलो next क्या है?
रोल नंबर 4.
थर्ड आया?
थर्ड को छोड़ दिया. 4
फोर्थ आ जाओ.
रोल नंबर 4. उसका लास्ट पे हाँ यार महावीर से जो फर्स्ट कैंडिडेट
हेमंत जी और रोल नंबर वाला लिख दे दो. BBC बैच का है इनके पास है? नहीं वो लिख दो. हाँ जी उठाओ उठाओ whatever you like.
कोई नहीं बस नाम लिखना.
ओके. ऐसा ये भी नहीं कि तुम वो पुराना वाली को उठा सकते हो.
हाँ.
Choice is yours. Whatever you like. उठा लो उसको. बोलिए क्या है?
पहले तुम्हें देखना था, मुझे दिखाना. अभी देख लो आराम से. कंफर्म कर लो.
There appears to be a specimen, a preserved specimen of kidney, sir, representing a growth.
No. Why did you why did you say it's kidney and then come on the abnormality and then normality?
How you identified this?
I can see the calyces joining together to form the PCS, pelvic calyces system.
Okay. The ureter is there or not?
I'm not able to see the
ये बोरा बिल्कुल राइट साइड में हवा में
ऊपर
ही ना ऊपर की तरफ है.
माउंटेन उल्टी है.
हाँ
साइड में.
हाँ बगल में.
देखा? Got it?
Yes, sir.
So what is the anatomically, what are the structures from anterior to posterior to renal hymen?
vein artery pelvis, sir. The renal vein is anterior most, and then it will be for posterior to that will be the renal artery, and then posterior to that will be the renal pelvis.
Now the pathology you wanted to describe?
Sir, there appears to be a growth which is present in the
growth
mass.
Growth. Better word use karo.
Mass.
Continue.
There appears to be a mass which is present in the upper pole of the kidney, which is extending till which is
ऊपर या
upper
ऊपर होगा क्योंकि उल्टा बोल रहा है ना?
Sir,
उल्टा है।
तो फिर लोअर होगा या ऊपर होगा? ये बेटा ऊपर जा रहा है नीचे जा रहा है?
Sir, बोल रहा है sir.
कोई बात नहीं, कंटिन्यू बताओ.
Sir, there appears to be a
polar region. ठीक है, polar region. चलो आगे.
polar region which is present.
ठीक है, polar region. Continue. Please continue.
Which is present in the upper half of the kidney, sir.
Okay. Characterize the lesion.
Areas of
It's a rounded cystic lesion with areas of
discoloration and necrosis, which is present in the
approximate size
of around 5 cross 5 centimeters.
क्या सर्जरी करनी चाहिए थी अगर ये तुम्हारे पास आता तो? क्या ऑप्शन थे?
Sir, it depends on the plan for surgery will depend on multiple reasons.
So in this case,
sir, it will depend whether.
What you will do in this case?
Sir, in this case, we will design the plan for surgery, seeing whether it is a single kidney or whether the patient has bilateral.
सिंगल किडनी होती और लीजन होता तो
So then we will have to.
दूसरी सर्जरी कर सकते हो.
Sir, but if it's the only solitary preserved kidney, then we cannot do a nephrectomy. So we will have to go for organ preserving approaches, maybe ablation.
तब तो दोनों किडनी हैं तब बताओ.
अगर दोनों किडनी हैं, then in the case we will
ablation in 8 centimeter lesion.
Sir, solid only kidney.
एब्लेशन कैसे करेंगे?
Enucleation or partial nephrectomy.
Enucleation is not term.
इनिशिएशन तो होता नहीं है देखो पहली बार.
Enucleation not term.
It is only the partial और कुछ नहीं होता किडनी के अंदर.
It's a solitary kidney, we will go with partial nephrectomy, sir. If there's a bilateral, if there's a contralateral functioning, well-preserved kidney, no other comorbids such as diabetes, presence of renal calculus, etc. is not available. Depending on the size of the lesion, 5 to 4 centimeters, it does not appear to be extending to the renal pelvis as well. We can consider partial nephrectomy for this patient. Because it's less than 7
kidney, we can
still consider partial nephrectomy for this patient, sir.
क्या इम्पोर्टेंस है पार्शियल नेफ्रेक्टोमी कैसे करेंगे? स्टेप्स क्या?
Sir, first we will have to we should have a skilled surgeon for this. We should
स्किल्ड के बिना
You are skilled surgeon.
Yes, sir. Yes, sir.
स्टेप्स बताओ. आपने एब्डोमेन भी खोल दिया, अब क्या?
Sir, after we खोल दिए, first we will do a thorough laparotomy to make sure that it is not a metastatic disease and unfortunately the patient is a candidate for surgery. Intraoperatively, we will first make sure that the disease is operable, seeing the extent of the disease, whether it has extent to the adrenal.
सब हो गया, पार्शियल नेफ्रेक्टोमी करनी है, प्लान कर दिया है मैंने.
Yes, sir. And then,
स्टेप्स बताओ.
sir, first we will start with dissection of the renal artery to make sure that we are exposing the lobar and the segmental arteries and the lobar artery. And then depending on the extent, the corresponding supply to the lesion, we will clamp those arteries, making sure there's a warm ischemic time less than 20 minutes. Then we start with dissection of the capsule first and then deepens it.
लोबार आर्टरी तक पहुंच जाते हैं. होता है.
So capsule, once the capsule is dissected, we will be able to visualize the lobar artery. Lobar artery.
आर्टरीज आपने देख ली, वेन आपने आइसोलेट कर.
हाँ सर.
फिर अब
कैप्सूल पे इंसिशन लगाते हैं सर, एंड देन वी स्टार्ट
बस सीधे ही
सर
एक स्टेप
कंट्रोल वैस्कुलर कंट्रोल गेन करना चाहिए.
कंट्रोल तो ले लिया, उसके बाद आप क्लैंप नहीं करोगे?
Clamp लगाओगे ना?
क्लैंप नहीं लगाओगे?
On the arteries.
हाँ सर.
तो वैस्कुलर क्लैंप कहाँ लगाओगे? कितने % केसेस में आपको दिख जाती है 2-3 आर्टरी? बहुत, इट इज हार्डली आई थिंक 15 to 20% केसेस में दो आर्टरियाँ भी दिख पाती है कि आगे से डिवाइड हो ना। जनरली तो एक ही होती है, आप अंदर तक डिसेक्शन नहीं करते हो
जो
मेन आर्टरी पे ही जनरली क्लैम्प होता है। हाँ, आपको पहले मिल जाए डिवाइड होती और अब एक पोल की तरफ जाते तब आप उसको लगा के चेक कर लेते हो यहाँ ये इस्कीमिया दे रही है उस एरिया को, तब तो ठीक है, ना मेन पे ही लगाना आइडियली।
And then you start with the parenchymal dissection.
Yes, sir. And then
How
we
much
start.
margin we take?
Sir, grossly clear margin is enough, sir. There is no specified margin for this.
So you cut the tissue.
We cut the tissue, making sure there's a grossly clear margin, that it is not focal, there's no positivity in the margin.
काट दिया।
Yes, sir. Cut दिया, and then after that we will have to, जो obvious the Kenicel system, whatever is the Kenicel system which is visualized, it should be suture. Multiple techniques are either single or double layered, absorbable, non-absorbable. After making sure we secure hemostasis, then we will release the clamps and see whether hemostasis has been secured. And then we can give a bolster cover for it as well. Sir.
How to do bolster cover?
So we can either use a mesh or we can use the surrounding peritoneal cover or connector.
Something else is coming in the market for the bolster cover?
Bovine collagen. I don't know.
No collagen. Yes, surgical bolsters are there which you can shape it like that, put on the cut edge of your kidney and suture over that. So that will cause a pressure tamponade effect also. So they can decrease the bleeding and complications.
Instrument.
बहुत सारे कोई भी
क्या
लंग रिट्रैक्टर
कैसे पकड़ते हैं?
वैसे ही दो हाथ से
एक हाथ का इंस्ट्रूमेंट होगा कि आप
नहीं सर, दो we'll have two instruments.
अभी एक है ना तेरा?
हाँ सर।
ऐसे पकड़ते हैं पक्का?
सर आई थिंक सो सर।
और कुछ तरीका है क्या इसको पकड़ने का? ये ऐसा क्यों बनाया है? चलिए ये जो है ना, ये एंगल क्यों बनाया गया? ये एंगल दिख रहा है बीच में।
ये सर।
ये क्यों है?
So we should be able to go beyond the thoracic cavity for use for open thoracotomy, sir.
तो मुझे तो ठीक है, thorax में ओपन नहीं करेगा।
Why there is angulation? Simple question. What is straight भी हो सकता था?
सीधे भी हो सकता है।
सर ऑपरेटिंग फील्ड में नहीं, हाथ नहीं आना चाहिए।
How to sterilize it?
Autoclave.
प्लाज्मा कोई प्लाज्मा बोलो कंपनी वाले फिर कैसे काम करें? चलो ठीक है, और चिट ले लो।
Intergroup 01165.
सभी ट्रायल है। ये तो उसकी पर्ची क्या है?
टॉप गियर। टॉप गियर ट्रैक।
क्या नाम है?
Intergroup 116. Sir, I'm not sure. कुछ और
There's no choice. चलो ठीक
फिर
कौन सा आ गया?
Sir, NSABP 06 sir. This was for breast conservation sir. B06. NSABP B06, one of the trials for breast conservation sir. Was done for T less than 4 centimeters, N0 or N1 patients. And they compared breast, there was a lumpectomy arm and there was a lumpectomy plus axillary dissection plus RT and a mastectomy plus RT arm. So they proved that local recurrence is similar. The lumpectomy plus RT is
नहीं, there's a difference.
Local recurrence similar कैसे होगा?
Similar नहीं, difference is a percentage कोई, it's less percent, it is there.
almost similar difference. Survival was similar, sir. Survival is not going to be similar between.
Why local recurrence similar नहीं होगी? चलिए बताओ.
Sir, there's no breast.
Obviously, mastectomy में you leave everything is removed. वहाँ पे तो आपके breast बचा ही है.
Overall survival was similar between the lumpectomy arm and the mastectomy also.
Even in mastectomy, the local recurrence is not zero.
थोड़ा बहुत breast tissue छूट ही जाता है. Just one recurrence.
Just
How many veins you ligate when you do a X-ray dissection? Name the veins you ligate in X-ray dissection. Not arteries.
काउंटिंग.
So there's an anterior.
चलो काउंटिंग बता दे कितनी बार. नाम आए तो अच्छी बात है.
चलो arteries.
मैं एक ही vein ligate करूँ. Sir, the axillary veins we have an anteriorly placed.
Which? What is the name of that?
नाम क्या है?
चलो vessels के नाम बताओ which you ligate in MRI or X-ray dissection. You ligate vessels. If you ligate, yes. Then what are the names of those vessels?
We ligate an anterior.
Left and right we do it.
So there's a draining anteriorly placed vein. Which is
draining vessels are there. Tissue है, dead tissue नहीं है तो draining तो होगा. Name the vessels.
डायरेक्ट
एक नहीं सर एक एक्चुअली वेन के अंदर सामने जाती है जिसके पीछे वी हैव दी
तो सरफेस एनाटॉमी हो गया. What is the name of that vessel?
हमें भी पता है, सब समझ में आ गया कि उसी को बांधना है, सबको पता है. तो बांधता भी है, रोज बांधता है.
आई थिंक लैटरल thoracic means lateral thoracic artery, lateral thoracic.
Next. Okay.
है क्या ये? नहीं तू तो देखो. अच्छा वो कौन पे है?
Start. Scroll. दिनेश में कहाँ से खतरनाक चीजें लेके आता है.
क्या देखा था?
The angle on the left side. Why? What is this image? Describe it first. What the आवाज नहीं आई. माइक लगाओ.
There is a coronal section of an MRI.
Of the MRI coronal section. MRI का coronal section है.
MRI coronal section of
MRI image, coronal image of an MRI.
Of an MRI.
of
Sentence सही करो.
head neck क्या है? head बना.
Not sure of what. Image or MRI?
MRI.
तो T1 and T2 है.
T1
कैसे T1 कैसे है? T1 कैसे? तो इमेज बदल दी.
लिखा हुआ नहीं है कहीं पे भी.
ऐसे थोड़ी. हाँ तो क्यों है वही बता दे तो.
Sir, the vascular structures were not quite intense, they were not hyperintense. They were hypointense.
Blood.
That's a T1.
Blood.
Yes.
तो सही कह रहा है.
रोड लतीफ बोलना चाहिए.
तू इमेज बदल दिया यार. हमें भी तो याद करना पड़ेगा यार. कैसे करना है? गलत बात.
Going for the easiest image. चलो हीरो उतारो तो हीरो.
इतना टाइम.
पीछे ले एक
पीछे
यहाँ बेस ऑफ टंग नहीं होगा. हाँ ठीक है. बेस ऑफ टंग ठीक है. Just be here only, not one place.
एक जगह तो रुक जा यार. अच्छा क्या करेगा कल?
हाँ चल जो
एक समझ में आएगा. अब बता.
Which area? No. It's an axial cut. It's not the axial.
Axial cut.
बोलो आप. Continue.
Is an axial cut T2-weighted MRI event of the region before the hyperintense region present in the right lateral aspect of the tongue, extending the midline and involving the base posteriorly extension
Where is the masseter muscle here? Masseter.
which is extending to the right corner of the surface, posteriorly on the right side.
ठीक ठीक है है ना
First question, classify RPL and D. Come sit down.
सुनाई नहीं देता
चलो
So start with specific.
तो सब लोग पहले ही सोच रहे ना आप क्या क्या उठाना है यहाँ से मत
यहाँ से वहाँ तक देखो, पूरे स्पेसिमेन देखो पहले, फिर चूज करो. जल्दी ट्रेनर नहीं करता.
चॉइस देनी नीचे समय खराब होता है चॉइस देनी. उठा कर ले आओ.
हमें भी तो दिखा दे अरे तू देख ले आराम से कसर लीजिए हमें भी दिखा देना आगे कर उठा ले स्ट्रेट उठा ठीक है चलो बढ़िया क्या है
In which year Halstead did the first radical mastectomy?
Right job.
तो आपने क्या सोचा हम एमआरएम के बारे में पूछेंगे आपसे आपने बेस्ट स्पेसिमेन ले लिया तो फिर सेम क्वेश्चन पूछो which year he did the first radical mastectomy? So what was his surgery exactly? What surgery he did Halstead? Mike. You take easy thing, we'll ask you easy questions.
ये वाला ले ले इस पे आवाज आई उसमें नहीं आएगा
What was the difference between Halstead mastectomy and modified? What is the difference between Halstead versus modified?
कोई बात नहीं सुन लेंगे तो बोल तो
हेमंत देखा ना माइक दे.
Sir, Halstead did it radical mastectomy. He removed, along with the normal modified radical mastectomy, he removed the pectoralis major muscles as well as the pectoralis major muscles.
What else?
But it was very radical surgery.
So why it was very radical?
So that time it was according to the Halstedian story, it was a local breast cancer was a local disease.
No, I'm not asking the principles of Halstead.
क्या निकाला स्ट्रेट
क्या निकाला आपने सिर्फ एक पेक्टोरल मेजर बताया.
So the entire breast tissue, along with the pectoralis major, minor, and
What else? Now don't say chest wall.
so
What else? You remove more things, more structures other than what you said.
serratus.
You are asking, you are telling.
So I
चलो स्पेसिमेन पढ़ो.
So it is a formalin mounted specimen of the breast and the entire breast tissue. You can see the nipple along with the skin, and there seems to be a growth. Which, so it is a
Seems to be a growth or there is a growth?
बिना ग्रोथ के तो क्यों निकाला होगा
there is a growth. So it seems to be a modified radical mass.
एक्सिला किधर है
Right side, left side नहीं बोला.
So that's
How?
this seems to be the axilla.
तो उसको उल्टा कर देंगे तो नहीं
So this seems to be the axilla towards the.
ठीक है तो क्या
What is it? What is a dermoglandular flap?
किस में करते हैं BCS पढ़ा है
So BCS volume displacement is there. So the whole triangular flap.
Please. Instrument. She's confused.
Sir,
You see how that will be a tough one, huh?
सर आप दे दीजिए तो
मृणाल के टाइम पे सबको ही देना so मृणाल के टाइम पे आपको ही देना चाहिए था मुझको उसको टोकने के लिए.
What is this?
Suction catheter.
Suction catheter?
Suction, the metallic suction.
Metallic suction? You don't know.
It's a metallic suction. I according to me.
You don't know what this is.
फाइन टिप सेक्शन नहीं है. फाइन टिप सेक्शन है नहीं. तो कहने में दिक्कत क्या है?
मैंने तो बोला था suction.
ये fine tip है.
Suction है. This is a metallic suction.
Metallic suction. क्या नाम है इसका?
Young man's game.
नाम बताया सर
Hint दिया.
क्या करते हैं ये किस लिए यूज हुआ था सबसे इम्पोर्टेंट कहाँ फर्स्ट टाइम क्यों यूज हुआ था ये शेप की वजह से और कहाँ यूज हुआ था किसने यूज किया था सर्जन ने तो नहीं किया था. चल अब बता. अरे सर्जन से पहले कौन होता है?
Dos.
एनेस्थेटिस्ट होता है. यॉन्कर्स ने सुना कि
Spell it out.
YNKUKUEU1.
शेप की वजह से किया था इसको इसलिए एनेस्थेटिस्ट यूज फर्स्ट शेप क्यों ओरल कैविटी में सेक्शन करते ना अंदर नीचे तक जाते.
What are the other types of suction cannulas you know?
Disposable suction, which is made of plastic. And
What are the components of that suction? You used it. You use it daily. So क्या होता है?
so there's a tubing and the front there's a suction tip.
And
Suction tip, neck, body. Right?
Suction tip.
Neck body classify कर दो.
And
सबसे आगे आप सबसे लास्ट क्या होता है उसमें?
So the suction machine.
and
The rubber around it.
हाँ
The joint.
हाँ वो क्या होता है?
So,
What
so
is
that
that?
there is no undue continuous pressure.
So
उसमें एक छेद होता है.
हाँ.
क्यों होता है?
So there is no continuous pressure, otherwise the tissue can also get sucked in.
there is a hole in that,
Yes, sir.
and over that there is a plastic
Yes,
cover.
sir. So that is harmless.
Normally it is there. You don't normally do anything. You just use it like that. Where you don't want too much of pressure or you want to control the pressure,
Then you open it.
you open that and you put your finger
Yes.
there, and then you control and then.
Yes, sir.
तो इसमें बोलने में क्या दिक्कत आ रही है?
So undue pressure नहीं करना.
वो तो बताया नहीं कि होल होता है वहाँ पे प्लास्टिक कवर होता है. You can control that. Do certain things. और कैसे टाइप का सेक्शन?
और सेक्शंस
वो जो डॉक्टर नितिन ने बोला था.
So jack or fine tip section.
तार यूज कर
So fine surgeries in a small field or when we are doing like for example we are doing hilar dissection.
Hilar.
हाइला
Which hilar?
So porta hepatis. If you are doing deep inside the abdomen, we are doing the fine dissection. Or if you are doing an anastomosis of the vessel.
सबसे कॉमनली फाइन टिप कौन यूज करता है?
Comness site. Comness site. Which surgery? Fine tip is used.
Thyroid surgery.
Keep your hand down. So you have more common thyroid cancers in your center.
Thyroid, parotid,
Head and neck.
limited. There is
स्पेस छोटा होता है आपको देखना तो हम वहाँ पे फाइन टिप यूज करें.
Why there are a lot of fenestrations in the tip of this section? There's one center big one and the peripheral small center.
So for the liquid to get suctioned out,
What was the need of putting so many
surface
holes?
area.
Kiska surface area?
So for the
If the center gets blocked, you get suction on the side.
Surface area क्या होता है? तुमने बोला what is surface area? How do you calculate surface area? And what is the difference between surface area and surface tension? जो चीज वर्ड बोलोगे उसी का क्वेश्चन. Try and speak as little as possible and very specific.
बड़ी के चिट देखना.
इसका एक पार्ट और होता है बच्चों. इसी लेयर्स का एक पार्ट इसके अंदर एक सीमेंट भी होता है.
Clean करने.
So that अगर ब्लॉक हो जाए clean कर सकते.
इसमें से होगा.
Cleaner.
Wire.
ovarian laparotomy.
Okay, I'm not. पानी पीना है?
नहीं.
मैं नहीं पूछूंगा तुम. आप पूछो.
So ovarian laparotomy, the indications and the contraindications. Indications if a patient, the patient with carcinoma ovary and we are going either for a staging laparotomy or we are going for a staging laparotomy.
एक हो गया.
हाँ, staging.
और इंडिकेशन.
Otherwise we are going for interval debulking surgery.
एक ही बात है.
So ovarian laparotomy.
ओवरी के लिए कर लिया तो एक ही बात होगी ना. ओवरेक्टोमी होगी ना. एक कैंसर ओवरी एक इंडिकेशन हुआ. सीए ओवरी एक इंडिकेशन और इंडिकेशन.
So CA ovary मतलब all types of.
सब हो गए. सीए ओवरी हो गया. अब और इंडिकेशन बताओ.
और ovarian laparotomy.
क्वेश्चन क्या है?
Ovarian laparotomy.
इंडिकेशन क्या हुआ फिर? एक तो कैंसर में कर लिया तुमने. सीए ओवरी मान ली. अब और बताओ. और कहाँ करते हैं? कहाँ करते हो? अरे क्या कैंसर ही है क्या तुम्हारे जीवन में?
So if there is any
MCh सर्जिकल ऑन्कोलॉजी
ovarian mass.
मतलब बताओ मुझे.
Ovarian mass of the ovary or
ट्यूबरक्लोसिस में कर देगी.
any it can be of any cause. If we've already given the.
चलो और कौन से कैंसर में करते हैं? ओवरी कहाँ निकाल देते हैं? ओवरी ओवरेक्टोमी को और कहाँ करते हैं?
Sir, सिर्फ oophorectomy साथ में oophorectomy we can go for metastatic CA breast.
मेटास्टैटिक सीए ब्रेस्ट.
If we are going for साथ में.
कितने? खाली. अच्छा चलो ये भी एक इंडिकेशन.
Only sir.
और
So if it is if you're doing any other surgery in the region and you think that ovary.
ये रास्ते में आ गई हमने उड़ा दिया उसको.
So if it is a postmenopausal woman and it is in the we want a R0 resection we can take out.
प्रीमेनोपॉजल तो छोड़ देंगे. चलो ये इंडिकेशन थी. ये तो ठीक है अलग बात. और कहाँ करें? एक तो मेटास्टैटिक सीए ब्रेस्ट बता दिया. और
oophorectomy only.
सी ब्रेस्ट में एक इंडिकेशन है मेटास्टैटिक सी ब्रेस्ट फॉर ओवरेक्टोमी.
So only if you want a surgical endocrine ablation then only.
That is the one with metastatic setting.
क्या होना चाहिए था तुम्हारा आंसर यहाँ पर? Any ER, PR positive, pre-menopausal.
Any ER
नहीं. Pre-menopausal में करोगे ना.
Aromatase inhibitors also because if you are doing oophorectomy it will be common in all.
ये तो क्वेश्चन. तो आगे के आंसर मत बता. क्यों करा वो? उसका आंसर देना बेटा.
Endocrine ablation whenever we want in a carcinoma breast we can go.
You heard what he said.
Yeah.
Indication will be if the patient is ER positive. If the patient is pre-menopausal.
Yeah.
Even in normal adjuvant settings.
It's a news for you or it is something else?
She's asking what.
मैं ये पूछता हूँ इससे. मैं she answer हम तक पूछ रहा है.
मनीष है ना. 2 times मनीष जी ने आंसर दिया था इसका. क्या? It is a crime not to do in a young patient, not convert her in pre-menopausal to post-menopausal. Now what? Right?
So it's a news for you or it's
It is just a confusion.
okay? Just a
Then ovarian laparoscopy will give an incision from the xiphisternum to the indication of
Xiphisternum incision दोगे?
Sir, if you do a proper staging laparoscopy.
Xiphisternum.
तुमने स्टेजिंग लेप्रोटोमी इतनी सारी करी होंगी ना, कितने केसेस में तुमने जिफिस्टर्नम तक इंसिजन लगा दिया? सिर्फ आंसर हाँ कितने लगाए, कितने में लगाए तुमने ये बताओ मुझे।
What is the aim of cutting at xiphisternum for the laparotomy? Why you want to do that? Why you want to go up to xiphisternum? Just simple question. In ovarian laparotomy.
Sir, if you are aiming for CC0 or 1.
CC0 xiphisternum काटने में CC0 ज़्यादा होता है क्या?
CC0, but you need a proper exposure, and if you are going to dissect the paraortic roads and.
Paraortic, you don't have to go to xiphi. Up till umbilicus also you can do good paraortic.
आजकल तो लैब से ही कर देते हैं।
हाँ. That is only for you have to go supra-umbilical for 5-6 centimeters, sufficient to take out the omentum, total omentectomy. That's all. There is no need to go to the xiphi. Aim क्या है आपका? To do a total omentectomy. यही aim है. अच्छा. So xiphi तो मत बोलना
There
आपको.
are on the diaphragm, the lesions on the diaphragm, and we are aiming for CC0.
Then you can say, in that setting you can say, but not in all the cases.
All cases में नहीं ना।
Nice.
अच्छा, image।
चले जाओ, वहाँ चले जाओ।
इसमें देख लेना,
लैपटॉप
लैपटॉप पे देख लेना।
बैठ के देख लो आप आराम से।
ज़्यादा अच्छा।
एरो लो फटाफट स्टार्ट रीडिंग इट, प्लीज बी फास्ट।
कौन सी इमेज है सबसे पहले ये बता दें। उसमें देख के
There's a mammogram, videolateral view, and
बोलिए ना, स्टार्ट करें। विंटर नहीं आ रहा, राइट क्लिक करो। आगे तो थर्स्ट टाइम। चलो ये सेक्शन। ओके, टेक दिस पॉइंटर एंड गो। कुछ भी उठा लो आप।
जो मर्जी आए उठा ले यार। आँख बंद करके उठा ले मनीष। 108 नंबर देख ले। MRN तो अभी तो किया है यार, बार
करने देना, अपने बारे में पूछेंगे ना, उसको उठा दे तो
कुछ और सबका हो जाए।
अच्छा,
कुछ भी और उठा ले। ये उठा ले, चलो ठीक है। कमांडो उठा।
हार्ट लग रहा है मेरा ऐसा। मुझे तो हार्ट लग रहा है छोटा सा।
108 नंबर। अच्छा उठा लिया, चलो।
एग्जाम में ऐसे तैयार ठीक है ना, जब एग्जाम से बोर हो जाते हैं तब तक वो रैंकिंग
मनीष 108 नंबर। मनीष 108 नंबर, चल आजा, छोड़ बाकी सब। तो 108 नंबर उठा ले, तो देख ले उसको ना। 108 देख ले यार।
बड़ी देर में चूज कर। ये दिनेश ने ऐसे इसमें दिखाया उसको कुछ तो चलेगा।
बताओ।
माइक प्लीज।
माइक ये वाला, वो वाला ये हटाई दे।
मैंने जो आपसे बोला कि किधर बैठो सुनाई नहीं दे रहा।
Component of small vowel and part of the sentence. When the sentence with the appendices and appendix visualized here, and these are the inner values.
ग्रोथ कहाँ है?
You said appendix and appendices. What is the difference?
No, it's an appendix. Appendices is basically. It's an appendices.
Appendix.
Over the. So
What
overlying.
is the difference between appendix and appendix?
Appendix is a part of a small bowel. That's part of a bowel. And appendices are overlying fatty structures over the colon.
What do they contain?
They contain fat along with the vessel.
Vessels. Supposing you take off all these appendices, what happens?
Sir, colon has a precarious blood supply, so the segmental, this, what you mean is the
circumferential
vascularity would compromise in this.
They can get
Also, it is not advisable.
It looks as though there is no problem, they are there, you can cut it. In laparoscopy, what do they help? How do these appendices help?
Somehow, if you are doing some surgeries in which the colon is bulky, the appendices, the assistant holds, you can ask the assistant to hold with the power forceps the appendices, because there could be that if you hold the direct colon in a loading, then that may lead to a cirrhosis or even the perforation of the bowel.
And appendix, structure of the appendix?
So, the appendix is a part of a bowel.
What is the structure of that?
Layers.
Layers are from inside outside. It is mucosa with having lamina propria with muscularis mucosae followed by muscularis propria followed by
Missed one thing between the two.
submucosa. Okay. And
What
then
is so peculiar about the appendix? Any peculiarity about the appendix?
so it's a vestigial organ.
It is a vestigial, but can be notorious at times.
Yes, sir, it has a blind end, and if anything gets obstructed at its name, then that will lead to a closed loop obstruction, leading to many complications.
That is one mechanical obstruction. What else?
Around what, sir?
Peculiarity.
So it has appendix. So it can be embryologically absent in few people, or it can have a variable positions in different individuals.
Morphology. Now, another
Histological features.
That valve by Ocrober, I think all.
क्या चीज होती है, क्यों ट्रबल कर सकता है?
It's a one-end valve, sir. One-end valve at the opening.
Oncology में, supposing oncology के ऊपर बात करें तो oncology में कहाँ दिक्कत दे सकता है?
Oncology में it can this organ can be confused with some other pathologies also.
Histology wise, चलो.
Histology wise, yes, sir. If you are talking about histology wise, the mucin which is being formed, and that can give a confusion of the origin or even the
एक ही चीज बोलो,
mucin,
mucin
sir.
तो क्या होता है?
That if there is a growth or there is something, either it is adenosis or even adenoma or even the CA of it, that mucin gets hypersecreted and that leads to perforation of the tip, leading to the jelly-like fluid spread over the intraperitoneum, and that is known as the thing. Depending upon the situation, sir. PMP, if it is adenosis, if it is malignancy, then it is disseminated DNB, sir. Disseminated malignant DNAP, sir. सर वो फुल फॉर्म नहीं मुझे पता, पीएमपी का एक सर सुडोमिक्सोमा बट डीएनपी हो जाता है, डीएमएपी हो जाता है शायद.
तो सुडोमिक्सोमा
सपोजिंग
अपेंडिक्स में और क्या चीज होती है जिसकी वजह से और कुछ डिजीज हो जाता है?
द प्रेजेंस ऑफ द periappendiceal lymph nodes can get enlarged and that may
म्यूकोसा में किसी में कोई टाइप ऑफ सेल्स होते हैं जिसकी वजह से एक टाइप का ट्यूमर हो सकता है. अपेंडिक्स में क्या
जिसमें कुछ सिक्रीशंस के इशू
Goblet cells are
कितना है
more abundant.
रेयर है मतलब
और कुछ हो सकता है
सिक्रीशंस होते हैं
Secretions जिसमें
सिक्रीशंस
एंडोक्राइन कुछ secretions निकलते हैं
कार्सिनोइड नहीं बोल सकता क्या है यार
Neuroendocrine tumors
न्यूरोइड कार्सिनोइड न्यूरोइंडोक्राइन
syndrome.
तो cells with specific
Goblets.
No, but you are specifically in appendix. It can be present in other part also. Appendix cells.
पूरी colon में होता है नहीं होता है
नहीं पूरी को
Considered appendix में
in the appendix, but in the small bowel, sir, it can be.
but appendix का specifically अपन histology पूछा
So, sir, yes, cells are there.
चलो
Instrument.
तो बता दें specifically
सर आपने अपेंडिक्स इतनी पूछ ली
सर आप ये बता दीजिए सर क्या नहीं सर कोई नहीं है
वो कुछ भी उठा के आँख बंद कर कड़ कर ठीक है क्या है
So this is the GI stapler DST.
What is DST?
Double staple
What is T?
technology.
This is the right DST का ये full form होता है क्या?
NTLC होता है DST होता है सर.
Uses
It can be used to in the various GI malignancies or even in the any GI surgeries also. Either to do the anastomosis, either end to side to side, or even in the even to divide the specimen also. So it can be used, and it's basically a brain.
Uses पूछा uses.
Sir, it is basically.
What else? और कहाँ? Can you be more specific on GI where you will use it?
Any?
Can you be more specific in your answer in GI where you will use it for
ये कहाँ use
anastomosis?
It can be used.
Anywhere. There are other.
पहले चूज कर लेता ना इतनी देर से हो जाता खत्म करो ये ले ले
Sir, where present specimen of face.
खा क्यों रहा है तो रख ले यार ये तो पानी नहीं है टेढ़ा बेड़ा पड़ा है
Multiple septations are there, sir.
Multiple septations are there.
Yes, sir.
Oh, great.
क्या है क्या
Sir, cystic
Diagnosis.
is likely to be, sir, ovarian cyst.
Various cyst.
कैसे पूरी कैसे लगी कैसे लगी
Polycystic ovarian cyst.
Multicystic.
Multicystic ovarian. Okay.
और कहाँ का होता है पॉलीसिस्टिक
Sir, polycystic can be also in liver, in lungs, or spleen, and multicystic disease also can be in pancreas, in VHL, on nipple lindum.
What else? One thing which one organ which has multiple cystic lesions you left.
Spleen, liver, lung, or pancreas,
कौन बोले?
kidney, sir, yes, sir, kidney. Both.
अच्छा ये पॉलीसिस्टिक में सर्जरी करते हैं
हाँ sir.
सर्जरी
Indications.
In ovarian, sir. हाँ sir, we can go ahead with surgery, and on the on table frozen section, if there is malignancy, then we have to proceed with the staging level.
malignancy नहीं होगी
So, sir, we can in sex cord stromal tumor and borderline ovarian cystic tumor, we can preserve the opposite ovaries.
What is Shivashu's maneuver? Don't do that. Don't do that.
Seefing,
What is Shivashu's maneuver?
not related.
I think I'm loud. It's quite loud. What is tripartite phenomenon? What is, tell me the boundaries of Scarpa's triangle.
Scarpa's triangle.
Polycystic में क्या पूछूंगा भाई? Scarpa's triangle.
Chemo.
Scar pass तो you guys should know.
Sir, hand piece.
हर एक इंस्ट्रूमेंट में हैंड पार्ट, फल्क्रम, बॉडी, नेक, ये होता ही होता है लगभग।
हिंज होगा,
ये किस टाइप का जॉइंट है? किस टाइप के इंस्ट्रूमेंट में जॉइंट कैसा है इसका?
ये स्प्रिंग जॉइंट है सर।
स्प्रिंग है इसमें?
हाँ सर, बीच वाली सर।
ठीक है।
What metal it is made of?
Sir, it is not made of stainless steel sir.
What metal it is made of? Gunpowder कुछ होता है?
Sulfur.
Combination of 5-6 metals. Gunpowder. It is lighter in weight.
Yes, this is lighter.
It's very light. Uses. ये ऊपर नीचे क्यों होता है? एक आगे पे एक पीछे ऐसा क्यों?
Edentulous patient के लिए सर यूज करते हैं इसको, जो retracted.
So why this one limb is smaller or is longer?
Right left का तो नहीं सर, दोनों साइड।
सोचना या आगे पीछे क्यों है? डेंटलिस्ट वाले में तो ऐसा नहीं होता है।
हाँ सर, उसमें तो सेम लेवल पे होता है।
ये कैसा क्यों प्रॉब्लम है इसके साथ?
अपर और लोअर जो
जॉ की एनाटॉमी देखिए, मेरा मुंह खुलता है तो कुछ आगे पीछे चले जाता है, कुछ आगे रह जाता है। Upper is fixed,
lower is
round. So the difference is the lower trunk will always be longer, which will go in the mandibular sulcus, posteriorly RMT area.
Yes.
And the upper one will be smaller.
Yes.
So that's the reason that it is longer. Right? So the next. Chittu.
तो ट्रायल है सारी।
ये 116 ही आया सर। This is INT 1106 0116 is for the adjuvant CTRT followed by following the surgery sir. हाँ सर, for
ओरी, ब्रेस्ट।
नहीं सर, it is for J junction adenocarcinoma and stomach sir. There is a 3-year survival difference was there, overall survival difference is there, and progression-free survival was better in post adjuvant CTRT group.
कोई ट्रायल का तो अच्छा
सर।
Ultimate. हाँ ठीक है, चलते हैं बोलो।
ठीक है।
बोलो नेक्स्ट।
कंसिस्टेंसी कैसे?
Sir, there is some cystic area is there sir.
क्या कहेंगे? क्या वर्ड यूज करेंगे?
This is MRI CT.
CT.
So what you will say for that consistency in CT?
Heterogeneous sir.
Heterogeneous.
क्या करेंगे?
Surgery. What surgery for this case?
Sir.
बायोप्सी करेगा?
नहीं सर, for in case of there is a doubtful in diagnosis like lymphoma, leukemia or metastasis. नहीं,
इसकी बात कर रहे हैं ना?
हाँ सर।
What is the indication of biopsy in RCC?
Active surveillance or in case of tumor ablation.
Active surveillance. What does it mean? Case of this patient is there.
Yes sir.
What is the indication of biopsy in this patient?
इस पेशेंट की बात है ना, जनरलाइज बात नहीं कर रहे। यहाँ करेंगे।
You want to do biopsy or not?
No sir.
No need. When you will do biopsy?
Sir, in case of there is a differential diagnosis of leukemia, lymphoma, abscess. In this case, नहीं sir, this is not look like.
मैं इसी की बात कर रहा हूँ, renal tumor की बात कर रहा हूँ।
Yes sir.
Renal tumor में what is the indication of biopsy?
Sir, in case of frail patient or we can not go frontally with surgery or we can choose the ablative procedure, we need biopsy sir.
No, I don't think so. This is 3 centimeter lesion, frail patient, you can do ablation straight away.
But sir, ablative
What is the
procedure.
first indication of biopsy in RCC?
Metastasis sir.
Metastatic, extensive metastatic disease where you cannot do much of the debulking and you want to go for a nutrient protocols in the form of all these TKIs and all. It is the first indication of biopsy. बाकी सब secondary हैं, आपके जो भी करना चाहते हैं. Agreed with the frail patient, quite frail, 3 centimeter lesion, having some problems, you cannot do big surgery, go for biopsy. But common indication तो metastatic setting ही है.
Yes sir. Thank you, sir.
भेजा उठा ले जाओ खाना तेरे को कोई सा भी उठा ले पीछे वाली ले बोलो माइक ले लो टोटल
side
गैस total thyroidectomy special.
total thyroidectomy, we can see both lobes of the thyroid gland.
राइट कौन सा है, लेफ्ट कौन सा है?
उल्टा है सर.
मैं मेरे को ये पता राइट कौन सा लेफ्ट कौन सा, उल्टा सीधा कोई बात नहीं.
चलिए
उल्टा करा हुआ है ना, तो राइट है. ठीक है. टोटल
What is reef space?
Space of reefs is a space which helps in identification of external partner with superficial laryngeal nerve.
Superficial.
Sorry, superior laryngeal nerve. It is bounded by medially by midline.
Midline.
It is bounded by attachment of strap muscles, superior attachment of strap muscles.
Which strap muscle?
Thyroid. And laterally.
Are you sure?
Yes, sir.
No. No.
Thyroid कहाँ
It's too medial to it to be a boundary of reef space.
So in the medial position में लिखा है कि superior attachment of strap muscle.
So ठीक है, next. What else? What are the boundaries?
So laterally will be superior polar thyroid gland.
Yes.
Which helps in identifying the axis space.
टोटल की इंडिकेशन क्या है?
Total thyroidectomy, malignancy like papillary carcinoma thyroid, follicular carcinoma, medullary carcinoma thyroid.
Non-malignant indications.
Non-malignant total thyroidectomy
करते ही नहीं.
एनाप्लास्टिक में करते हैं.
Anaplastic में it is resectable, then sometimes.
What is the criteria of resectability in anaplastic carcinoma of thyroid?
Not limited to thyroid gland, no external.
7 centimeter lesions limited to 31 to do surgery. Then?
It is involving surrounding structure data.
Then classify your answer.
मेंटल स्ट्रक्चर इन्वॉल्व कर रहा है तो कैसे करोगे यार? फायदा नहीं है. सबसे कॉमन सर्जरी क्या है एनाप्लास्टिक?
Mastectomy.
आइडेंटिफाई पैराथायरॉइड. कोई है टेक्निक?
Ideally, is the most common location and you have to look for intersection of.
क्या क्या टेक्निक्स है? खाली वैसे ही ऑपरेट करते
The intersection of inferior.
टेक्निक्स टू आइडेंटिफाई पैराथायरॉइड क्या क्या है ये बताना.
Sir, we have to remove and put in the saline.
एक तो अच्छा मतलब निकाल के पहले सलाइन में डालें, ये क्या है तुम्हें?
That is one of the techniques.
ये टेक्निक नहीं, ये निकल जाती है तो सस्पिशन की वजह से करते हैं कि भाई कट चुकी है, हम ये देखना चाहते हैं पैराथायरॉइड है, सारी मुर्गी बचानी है इसलिए करते हैं. जानबूझ के काटा नहीं जाता है, इसको काट के पहले डिपोएंगे. इट इज नॉट. एक तो एनाटॉमिकल टेक्निक हो गई कि एनाटॉमिकली डिसेक्शन के दौरान फिर इसके अलावा और कोई टेक्निक है क्या?
Intraoperatively, sir, when you are dissecting around parasite gland, उसका कलर चेंज हो जाएगा.
कलर चेंज का क्या मतलब?
Means first you damage it and then
first you damage it
and then cut it in pieces and then put it.
दिस इज द सर्जिकल पार्ट हो गया ये ना. अब और क्या टेक्निक से आइडेंटिफाई करने के सर्जरी के अलावा की? इंफ्रारेड का कुछ रोल है क्या? ये कोई टेक्निक है ये भी? एक तो ये बोल रहा है
फ्लोरोसेंट कौन सा?
सर ऑटोफ्लोरोसेंस है
हाँ, तो इसलिए यूज करते हैं इंफ्रारेड, पता है।
देयर इज नो नीड ऑफ
No need of any dye for them. Just use the wavelength of this. समझा? Just locate them. स्किन के ऊपर से नहीं है, खुलने के बाद। इंस्ट्रूमेंट।
So what is this?
Sir, real approximate.
Full name?
आगे जो जुड़ा हुआ है वो नाम, इसके आगे कुछ लिखा हुआ है।
ये नहीं आता मेरे को।
Indications?
बताएंगे नहीं, वैसे बुक के नाम पर है। डेली
क्या क्या
ऐसे करते हैं सारा।
इसके पहले पार्ट्स बता।
पार्ट्स से वो सब कुछ
फटाफट इन्यूमरेट कर।
देखो सर,
पार्ट्स पूछ रहा हूँ मैं यार, वो तो बाद में देखेंगे क्या करना है।
स्लाइडर push button.
There is one fixed part, one mobile part. This is for rotating movement. It can come out.
ये सर वो टाइप करने के लिए,
Approximately.
This is for release.
क्या करने के काम आता है? क्या
सर रीडिंग thoracic cavity क्लोज करने के लिए to close the जो incision है फ्लूरा का, उसको
Pleura का incision. Chest wall.
chest wall incision को क्लोज करने के लिए विच रिप्स अप्रोक्सीमेटर 2 रिप्स पहले अप्लाई करने के बाद ये होगी टाइट।
रिप्स कहाँ होती है इसमें? 2 रिप्स कहाँ होंगी?
एक तो सर सुपीरियर एंड होगा सर रिप का, और दूसरी जो लोअर लिप होगा उसका इंफीरियर एंड होगा, वहाँ पे उसको फिक्स करके देन वी हैव टू टाइट करते जाएंगे, देन वी हैव टू टेक स्टे सुचर्स एंड
स्टे सुचर लेके हटा देंगे इसको।
Stay sutures.
स्टे सुचर लेके हटा देंगे।
नहीं पहले तो रखना चाहिए इसको, एक सूचर निकालेंगे, टाई करते जाएंगे, फिर इसको
पहले सूचर
पहले
लेंगे।
सुचरिंग पूरी कर देते हैं।
पहले स्टे सूचर ले लेंगे सर।
It is not called as stay suture.
स्टे नहीं कहते ना, प्रॉपर सुचर ही लेते हैं इसमें।
Sutures लेते हैं around the rib.
Yes sir.
So what precautions you will take when you're suturing the rib cage? When you're taking suture on the chest wall.
The axial cut section showing mass lesion. When we
What level it is?
at the pelvic region.
Approximately what level it is?
L5.
L5.
L का है।
L कहाँ आ गया यहाँ पे?
S आ गया।
ये तो सेंक्रम है बेटा।
इसको मत जाओ ऊपर नीचे, तो कह रहा हूँ
जो लेयर है वहाँ पे बात करो।
नीचे जा।
इसी जगह पे है। नीचे आ जाए थोड़ा।
थोड़ा सा नीचे आ। अब बताओ। चलो नेक्स्ट बोलो। स्ट्रक्चर्स क्या दिख रहा है?
Solid cystic mass lesion.
सिस्टिक कहाँ से आ गया? हिट्रोजिनस लग रहा है ये तो।
Heterogeneous energy solid mass lesion. Might be arranged on the pelvis.
अगले स्ट्रक्चर्स
Other structures.
जो है वही बता दे। यहाँ पर क्या क्या है?
क्या दिख रहा है? लेफ्ट राइट साइड में ऊपर डार्क सा नॉर्थ स्ट्रक्चर। राइट साइड ऊपर जाओ। लेफ्ट साइड सॉरी, यहाँ यहीं पे नीचे, यहाँ पे इसके पास में इंटीरियर टू इट मोर इंटीरियर। हाँ ये क्या है? इसके जो मांस है उसके चारों ओर क्या दिख रहा है? Res gluteus maximus, मिनिमस का है। मिनिमस वहाँ नहीं होती, मिनिमस इंटीरियरली होती है।
इसके नीचे होती है।
हाँ, डीप टू इट।
डीप टू तो ग्लूटियस मैक्सिमस होती तो इधर तो हो ही नहीं सकती ना यार।
इनसाइड बोन क्या कौन सी मसल है? ये
अंदर
लैटरल बोन कौन सी है? इधर लेटरल।
हाँ, ये क्या है?
कौन सी बोन है? ये मसल कौन सी है?
यूरेटर दिख रहा है क्या इसमें?
यहाँ पे कहाँ यूरेटर हो गया? डाउटफुल एरिया बता, यूरेटर का कहाँ पे दिख सकता है?
चलो कहाँ होगा यही बता।
एरो कहाँ पे? ये यूरेटर है। चलो स्टार्ट। यस प्रणव, ढाला जो तेरे अच्छा है।
जिसको हाथ लगा दिया
उठा ले, बस उठा ले अब। टेढ़ा मत कर, पानी गिरेगा। वैसे रख के देख ले, बैठ जा आराम से।
बोलो।
ठीक है, बता दे।
This is a forming fixed specimen.
The water is so muddy, cannot see that. I can say that also.
So it's not easy to see. So I
take another specimen.
वैसे ये रेयर स्पेसिमेन है।
कौन?
करते कॉमनली ये मिलता है। हाँ। प्रदीप सो प्रदीप देख लो अपना चूज कर लो।
बोलते यार, कुछ भी बोलते हैं। चलो कोई बात नहीं, कुछ भी ले लेते देखो जो अच्छा लगे। यू टेक ब्रेस्ट, यू टेक व्हाटएवर यू लाइक।
ठीक है, चलो
बोल दे
क्या
Forming specimen of ileocecal region showing the transition from the ileum into the semicolon, and
what is the difference in how do you identify during surgery that this is jejunum, this is ileum? Differentiating point during surgery.
Sir, jejunum will be slightly larger in diameter as compared to the jejunum. Secondly, from the mesenteric
comparison to
the ileum between ileum and the jejunum, so ileum will be slightly larger in diameter. Secondly, looking at the mesenteric arcade.
Second thing is the wall thickness of jejunum is more in comparison to ileum. Ileum is thinner. The wall is thinner. Here it is thicker. Then
we look at the mesenteric arcade, sir. So for jejunum, it will be multiple small arcades. But ileum will be single. It will be lesser in number. So apart from that, jejunum have
less and
no. Shorter vessels and ileum.
Yes,
jejunum will be longer.
Jejunum will be longer.
But wall thickness of jejunum will be more.
Yes.
So,
diameter is also.
Diameter is larger.
क्या सर्जरी करी है इसकी? क्या स्पेसिमेन, कौन सी सर्जरी का है?
Sir, looking at the specimen, what they've done is a limited resection, sir. Ileocecal resection they have done. Ileosecond resection, limited resection of the.
ऐसा कोई वर्ड होता है क्या? ऐसी कोई सर्जरी होती है क्या?
आइलियम निकाल दिया, आईसीजी सीकम निकाल दिया, जेनियम क्या बच गया? इसकी हाइट ही कम थी पेशेंट की, पूरी निकल गई इसकी।
नहीं सर, they've not done a proper right hemicolectomy.
अच्छा, कैसे नहीं कर?
Because for the right hemicolectomy, it's done on the vascular basis, so we have to take in the right branch of the middle colic.
So how do you know this specimen is not proper?
ये कैसे कहेगा ये?
When you will say it's a proper specimen?
Because that will entail hepatic flexure as well, and the momentum, the mesenteric part will be there. We'll see the vascular arcade extending to the origin. So we'll see all those vessels.
So it's a segmental dissection.
Segmental dissection.
Rather, but फिर भी say it is a right hemicolectomy specimen. ऐसा कोई वर्ड होता नहीं है कि आपने आइलियम और एसेंडिंग का पार्ट निकाला, आइलियम ऐसा कभी पढ़ा नहीं है ना, वर्ड है भी नहीं ऐसा। एक्सटेंडेड
Most probably करके
करते तो राइट हेमिकोलेक्टमी है ना बेटा ऑलवेज। ठीक है, तो क्या इंडिकेशन, मैलिग्नेंसी के अलावा इंडिकेशन बताओ।
So this could be this could be done if for a tubercular cases involving tuberculosis. So if it's a pulled up C curve which is almost about to perforate.
कब करेंगे ट्यूबरकुलोसिस?
So tuberculosis, if it's an obstructed lesion or a perforated lesion.
Secondary tuberculosis.
Secondary tuberculosis. Secondly, in
टाइप्स ऑफ ट्यूबरकुलोसिस क्या होते हैं?
So we can have ulcerative, hyperplastic, mixed, and then there will be peritoneal.
एक्सटेंडेड कब करेंगे?
So extended wheel is usually done for lesions of the hepatic flexure. So we do extended right hemicolectomy.
Till what level it is extended?
So we have to take the left branch of the middle cooling as well for the extended hemicolectomy, right hemicolectomy, apart from the right branch. So till that we'll decide on the margin of that.
We will save the left or take the left?
We'll take the left. For extended we'll take the left.
Instrument.
This is a backcock, sir.
Backcock हो गया। अब
इसके आगे का नाम?
नाम भी है इसमें कुछ ऐसा।
यूजर्स के आगे ये क्या काम आती है?
So it's usually used to hold tubular structures. So it's a non-traumatic tubular structure holding.
Non-traumatic tissue holding.
Tissue holding.
Thoughts?
So these are the finger bones. This is the ratchet, the box, and this is the tubular end with
arms.
The arms with fenestrations on both sides, so as to not compress whichever structure we are holding, and it's non-traumatic. So radical cholecystectomy. So this is done for
straight away steps.
So after giving, we can give either an upper midline incision or a subcostal incision. After that, we'll first explore the abdomen to rule out a peritoneal dissemination of the disease. After that, I'll start with the cattle crash maneuver, go to the parietic lymph nodes. If they are not enlarged, I'll progress further in my
Radical? Radical? What is the surgery?
cholecystectomy.
So you do cattle crash first?
Because I have to reach the
कैटल क्रैश किसके लिए करते हैं? किसके लिए करते हैं?
It is the left mobilization of the right colon.
ठीक है। और इसमें आपको पैराओटिक पे जाने के लिए किसको मोबिलाइज करना है? इसके जो ज़्यादा जरूरी है। What is more important? Cauterization है ना बेटा।
कैटल क्रैश तो इंडिकेशन नहीं।
कैटल क्रैश इसके इंडिकेशन में नहीं आता ना, वो तो थोड़ा सा ही करके वो तो कोलन तो नीचे हो जाएगी। डजंट मैटर ना, पूरा करेगा।
फिर क्या करोगे?
पैराओटिक पे लोड है।
Once we've ruled out dissemination with the parametric inputs, I'll start. After then I'll start dissecting the hepatorenal ligaments. I will remove level 12 lymph nodes along with the cystic and the pericolitocal lymph nodes, and I'll remove the posterior suprapancreatic lymph nodes. Once I've removed that, I've ensured that the gallbladder is free. I'll take 2 centimeter
Free from where?
Free from any surrounding additions or structures, which is whether it's going to the duodenum or the stomach. I'll mark.
पहले ही देखना ना।
So after that, I'll mark a 2 centimeter incision free liver margin around the gallbladder.
और क्या तरीका है?
We can do a straight away 4B5 lobectomy in the
उसके लिए क्या करना पड़ेगा? आपको 4B5 करना है। क्या स्टेप जरूरी है उसके लिए?
Sir, after I've dissected for 4B5, I'll have to find the portal caesura and So I'll have to define the branches of the artery in the vein which are supplying the 4-beam 5, and they have to be tied independently.
Hilar plate dissection.
Hilar plate dissection is the word. Go along the hilar plate dissection.
And then go with the right
side.
way and then ठीक है. अच्छा तो तुम्हारे से अगर नोड आ गया, सीलियक पे आ गया नोड तो
सीलियक पे
नोड बड़ा है. सीलियक तो तुरंत देखा ही नहीं है, लेकिन मैं तो कह रहा हूँ वहाँ पे एक नोड बड़ा है. क्या करूँ?
So celiac is well, if it's I'll send it for frozen, sir. If it is positive, I'll abandon celiac.
Read this. Take Yanko's section with you.
Yes, sir.
Yanko's section.
पॉइंटर के लिए यूज कर लिया. क्या इमेज क्या है वो बता दो.
So it's a normal section of the abdomen showing showing levels from the lower chest.
क्या?
Of MRI scan of the coronal section of the MRI scan of showing levels from the lower
Corner
chest.
section of the MRI scan.
So coronal section of the
It's a MRI scan.
MRI scan
Corner
is the
section.
coronal section showing levels from the lower chest to the pelvis.
pelvis ठीक है.
हाँ sir.
अच्छा जरा सा आ गया. ठीक.
So
abnormal क्या है ये बता.
So multiple lesions are seen in the liver, sir.
This is the adrenal on anterior to the spleen. Superior to the spleen is what? Adrenal is that? Enlarged adrenal gland. This one?
क्या है ये?
What is that structure? What is that structure? Adrenal gland है क्या है? तो क्या है?
देख उसके अंदर ये दिख रहा है कुछ. अच्छा T1 है T2 है.
So this is T2.
T2 है.
क्या दिख रहा है?
क्या दिख रहा है उसके अंदर?
Starry sky appearance.
क्या है?
बादल दिख रहे हैं ना? What is that structure? Okay. Stomach. Fundus.
Fluid है. Fluid और वो है ना. क्या करोगे? चल मल्टीपल है.
So this is probably suggestive of liver metastasis from a primary region.
Where is the duodenum here?
Not too sure, sir.
Where is CBD?
CBD कहाँ है देख.
CBD. So this one.
वो क्या है नीचे?
नीचे टेपरिंग क्या है?
टेपरिंग है ना.
ये नीचे आ. CBD T2 weighted image में क्या है?
So now
जहाँ वो खत्म हो रही है वो duodenum होगा ना यार.
this is MRCP showing multiple SOS in the liver with CBD is dilated. What is the diagnosis?
Multiple liver as well with.
What is the diagnosis?
It could be a primary liver or could be metastasis from another.
Primary liver you will have tapered CBD or dilated CBD.
पूरी लाइन बोली. Multiple liver as well with dilated CBD and taper end. क्या diagnosis हो सकता है?
Cholangio.
चल. Common क्या होगा यार?
Cholangio से simple
है पहले यार. चल. ठीक है चल. आ जा.
प्रदीप.
यही बताया ना.
बोलने दो.
कोई नहीं बता.
थायराइड है ना. बोलो बोलो. What are the parathyroid location at superior pole with percentages?
Parathyroid location.
Superior parathyroid position with percentages and inferior parathyroid position with percentages. Gray's anatomy. Specifically given. तो तुमने क्या थायराइड बोला तो कुछ भी पूछना नहीं तेरे को. चलो RNL
को कैसे आइडेंटिफाई करें? राइट साइड.
Identify the inferior thyroid artery.
कितने ट्राइंगल है इसको आइडेंटिफाइड करने के?
4.
है ना? कौन सा ट्राइंगल है उस हिसाब से बता दो. किस ट्राइंगल को तू बताना चाहता है? सबसे ज़्यादा कौन सा ट्राइंगल मतलब माना जाता है? जोल्स पता है? बता. बाउंड्रीज बता जोल्स की.
It's inferior thyroid artery, recurrent angina.
चलो ठीक है, आपको जोश नहीं मालूम. हाउ डू यू आइडेंटिफाई ड्यूरिंग सर्जरी रिकरेंट लेंजन राइट साइड?
चलो, मेथड्स ऑफ आइडेंटिफाइंग रिकरेंट लेंजन क्या क्या हो सकते हैं?
बस एनाटॉमिकल.
ठीक है, हो गया.
इंट्राऑपरेटिव नर्व मॉनिटरिंग
कैसे
है अपने पास? डू यू डू इट? व्हाट यू डू इट प्लीज टेल. डोंट गो हाफ थिंग्स. इसमें फंस जाओगे इसलिए.
तो मेरा अगला क्वेश्चन होगा कैसे करेंगे?
उसका कॉस्ट पूछेंगे आपसे.
पता है कैसे करते हैं? कैसे करते हैं पता है क्या? पता कर लेना क्योंकि ये क्वेश्चन जरूर आएगा. उसमें कहाँ पे होते हैं? चल अच्छा तब पता ही नहीं.
रिकरेंट लेंजन आइडेंटिफाई कैसे करोगे ड्यूरिंग सर्जरी?
फटाफट पता है. आखिरी लास्ट क्वेश्चन है मेरा इसलिए.
What is the groove known as? Tracheocerebral. कहाँ आइडेंटिफाई करोगे?
कौन सा लिगामेंट देखते हो? कुछ होता है?
Varus ligament.
Varus तो बहुत ऊपर चलेगा. First, at the lower pole, you identify the tracheocerebral groove. How will you identify that this is the nerve?
वेसल भी ऐसी ही दिखती है.
And where is the vessel situated which you are talking about?
इंफीरियर थायराइड.
Inferior thyroid.
किधर होती है? राइट में. मीडियल होती है लेटरल होती है?
कोई बात नहीं. इंस्ट्रूमेंट लो. कोई बात नहीं. जस्ट रिलैक्स. पानी पी लो थोड़ा सा.
चल लेना भाई.
ये सब आना चाहिए ना. Should be on tips. इसमें कोई एक्सक्यूज नहीं चाहिए. आप अगर लिखो ही
Lung holding force.
बोलो. Why it is fenestrated?
To prevent the trauma to the lung.
Trauma. 1. Second, make it lighter.
Make like to build the picture.
The top parts.
Ratchet, box.
Box what?
किस टाइप?
What is box? This is not box. That is very clear. What is the full name of it? This is not box. This is box joint. Next. Bolo. Traumatic, atraumatic.
Atraumatic.
Why?
Because it has serrations.
Serrations, which are smoother, not sharp, right? Not dentate also. Slip nikalo.
Transthoracic exovarectomy.
Bolo. Steps. जल्दी जल्दी 1 2 3 4 5 6 बड़ा बड़ा स्टेप्स. इंसिजन दिया, आगे पूछो. कहाँ दिया?
Left lateral position,
fifth intercostal. When you use fourth intercostal space, when you use sixth intercostal space.
When tumor is above high with the level of carina or upper middle mid-thorax.
What is upper middle thorax?
Upper part of mid-thoracic, I guess. Then
at the level of carina.
Then fourth, or on the lower esophagus, then the sixth.
Fifth, yes. Continue next. क्या क्या करा? Incision दिया. What is the incision known as? Types of incision for esophagus. Lateral thoracotomy, mini thoracotomy, enterolateral thoracotomies. होता है नहीं? So what you will do?
Thoracic, lateral thoracotomy, lung down.
हो गया. Next step.
Esophagus को mobilize किया. Esophagus vein को separate किया उससे.
Where do you do anastomosis in transthoracic?
we are doing either intrathoracic or we are doing either.
When you will do intrathoracic and when the other choice which you are saying?
In the G junction or low.
Which type of G junction you will do intrathoracic anastomosis?
For Sieverts 1 or 2. Sorry, Sieverts 3. That's how G junction.
Sieverts 2 and 3.
2 and 3. 2 and 3.
Epicenter should be down. Otherwise you will not have space, length for. And when you will do another, which another you are talking about?
Cervical anastomosis.
When you will do that? In transthoracic approach.
बचा क्या?
Middle thoracic.
Middle thoracic. Right. वो तो upper thoracic पे. ठीक है वो तो middle thoracic पे करोगे ना transthoracic. Bronchial artery कहाँ होती है? When you want to save it during transthoracic approach. Where you will look for bronchial artery? You want to look or you don't want to look? Because that causes torrential hemorrhage if you don't look for it. Location. Rapid fire filters. Take the pointers. नहीं ये ना ये अपना इंकुस वो चाय पीनी है और चाय पीछे बैठ go जाओ बताओ
फटाफट
what is this discuss this image please
Sitting in thorax.
Yes.
Axial view.
yes
Showing the
contrast without contrast
without contrast.
yes
No
contrast again.
This is the right lobe of right lobe of
which window it is
it's a
lung window say lung window right चलो next बताओ बोलो
एबनॉर्मल है तो बता दे यार
abnormality बोलो
क्या एबनॉर्मलिटी है
what
बता
is
दे
there
this is the right lobe of lung.
yes which lung you are talking which lobe you are talking about which lobe of the right lung
Right lower lobe.
no चलो describe the lesion please
Appearance lesion irregular margins. It will
बोलो where is the aorta good कौन सा लोग
मिडल का भी
posterior इतना कौन सा 2 लीटर डाल रहे हो
इंट्राट्यूमर क्यों नहीं डालेंगे डाई
एक्सपेंशन हो गया
सबक्यूटेनियस करते हैं सब डर्मल करते हैं पक्का नहीं करते नहीं करते क्यों नहीं करते अब वो नहीं करते पहले
स्किन
नेक्रोसिस होता है तो स्किन आपको काटनी ही पड़ेगी नाउ इट इज व्हाट इज मोस्ट कॉमन साइट टू पुट अ डाई आजकल क्या करते हैं पेरियोलर में कहाँ पर
जिस साइड ट्यूमर है उस
ऐसा कुछ नहीं चलो अब बता 3, 9 mainly 3, 9 and then 6 or 12
what are the boundaries
आजकल जो कंसेप्ट आ गए हैं वो 3 और 9 पे 6 और 12
वो सब मिठाई
हाँ सिर्फ कितना देते
Period.
पेरियोलर नाउ इट इज पेरियोलर
2 to 4 ml
मिथली अच्छा और ICG
ICD 0.1 ml per kg. 0.1 ml.
What are the boundaries of lower axillary dissection?
lower axillary dissection.
Lower axillary dissection. What are the boundaries of lower axillary dissection?
Lower boundary.
Lower axillary dissection boundaries all around. Second question, principles of sentinel node biopsy.
The node which the most common node, sentinel lymph node, is the node that take up the main drainage lymph node of the tumor.
Primary drainage.
When you are doing sentinel lymph node biopsy, what else you will remove? You have taken out the sentinel lymph node. What else you will remove? Or you will not remove anything else?
Any significant lymph node is there, we have to remove that.
So you have to
also.
palpate the whole area.
Yes.
Great. Next. Level student. सारा चेस्ट का सेट रखा हुआ है।
तो सारे बोले
कोई नहीं ये ले अच्छा इंस्ट्रूमेंट ले बेचारे ये आराम नहीं है।
What is this?
This is a fine tissue cutting seizure.
Is it fine? सी फाइन होती है
टिश्यू कटिंग सीजर।
टिश्यू कटिंग तो ठीक है। कौन सी क्या नाम है?
What is the name of stitch cutting scissor? छोटी सी। What is medicine bomb?
Medicine bomb. This is medicine bomb scissors. Tissue cutting, sorry, suture cutting.
अब तो फाइन बोल रहा था उसमें क्या खासियत?
इसके parts.
हाँ चल।
This is the finger goes. And this is the shaft, and this is the pivot joint along with this scissor, and this is the cutting
made of
stainless steel.
Sterilized.
What of it?
What left? एक
चिट बची ना? चिट बता। बस एक ही उसको।
एक बचा। केस बोलो anything
left adrenalectomy.
left
लेप्रोस्कोपिक कर पोर्ट पोजीशन बता। पोर्ट बता दे कल पेशेंट पोजीशन और पोर्ट पोजीशन बस खत्म।
Left right lateral position. Ports in the triangular fashion. We have to place one in the umbilical, one in the midclavicular left.
तो फिर ऐसा क्वेश्चन पूछेंगे कि आप हाथ नहीं लगा पाओ।
And one in the midclavicular line in the left hypochondrial. Subcostal region, and one in the iliac.
iliac नहीं
iliac तो नहीं है iliac तो मामर तो सबकॉस्टल हो गया ना।
चलो वो क्या है पीछे स्पॉटर। What is that? Popcorn appearance sort of. Yeah. What popcorn it is? What popcorn?
ये इमेज क्या है?
आज डॉक्टर राहुल है ना पॉपकॉर्न फोटो खींच लाया।
तूने ये बता दिया टॉपर है।
Yes. Spot diagnosis. No ifs and buts.
इसमें और कोई सवाल भी नहीं पूछेंगे। नहीं वो टाइम गया।
बोलो। मैमोग्राम ब्रेस्ट का है इसमें। फाइब्रोइड में है क्या पॉपकॉर्न तो उसी में दिखता है कैल्शिफिकेशन।